Hi there. In this video, we are going to start chapter 6 of Robbins Basic Pathology, which is about neoplasia. So, what is neoplasia? Neoplasia basically stands for increased cellular growth or increased cellular division. So, this cellular growth or cellular division is basically uncontrolled. So, neoplasia is a kind of uncontrolled cellular division which leads to the production of tumors. Okay, so basically neoplasia is the formation of tumors in the body. So why neoplasia occurs or why there is production of tumors? It is basically always initiated as a result of some kind of mutation in the DNA or the nuclear material of the cell. When there are mutations, these mutations lead to the down regulation of the cellular regulatory process, and when cellular regulatory processes are down regulated, cells continue to divide at an increased rate. Okay, so growth rate increases and tumors are produced, and these mutations are hereditary, or it means here that they are transferred to the offspring cells. Okay, supposedly this was a cell here, and it was here was its nuclear material, and there was a mutation here, then it led to the daughter cells, and these daughter cells will also inherit this mutation. Okay, and next daughter cell will also have mutation, and not only this mutation pass on, in fact when there is constant division, these mutation continue to the amplification, and more mutations accumulate inside the cells, and these offspring cells are subjected to the Mendelian selections. What does it mean? It means that among these cells, those cells survive or continue to grow which have best genetic setup to attain autonomy. It means that they become self-sufficient for their growth and continue to divide without any regulatory sequence. So among these offspring cells, some cells are mutated in a way that they can no longer divide, or they are weak cells and it does not divide. However, some cells in response to this mutation become strong enough to become self-capable or independent, and they continue to divide independently and lead to the formation of tumors. Okay, next is cancer hallmarks. What is cancer hallmarks? These mutations which are passed on from cell to cell, they lead to the development of certain properties or a set of characteristics to the tumor cells which make them self-sufficient to continue their growth, and these properties or these set of properties are called cancer hallmarks. What are these properties? These properties include that they alter their metabolic systems, they continue to grow without any regulatory pathway, their tumor suppressors genes are down regulated, and they promote angiogenesis, and they undergo they prevent themselves from the immune system, and they are subjected to the local invasion as well as metastasis. So these are different properties which tumor cell attain, which are called cancer hallmarks, and we will study them next on in the next lectures. This lecture is based on the nomenclature of the different neoplasms. So broadly, neoplasma tumors are classified into benign tumors and malignant tumors. And benign tumors are the those ones which have an innocent behavior. It means that they are localized to their site and don't invade to the surrounding tissue and don't metastasize to the different distant sites. However, malignant tumors are those tumors which are aggressive in their behavior. They invade and destroy the surrounding structures, and they show a crab-like pattern. It means that they stick to the surrounding structures and invade them and destroy them. So malignant tumors are aggressive ones, while benign tumors are the innocent ones. And moreover, we should know here the parts of the tumor. Tumor basically have two parts. One is the parenchyma of tumor and other one is the stroma of tumor. So what is parenchyma? Parenchyma is basically cells that are comprising the main mass of the tumor, or the cell from which the tumor arises. So these cells formulate the parenchyma of tumor, and the characteristic of tumor are greatly defined by its parenchyma. While stroma is the surrounding cells as well as inflammatory response, or you can say when there is tumor, leukocytes accumulate there, and these leukocytes and inflammatory cells surrounding this tumor as well as blood vessels going in here and other stroma here makes the stroma or the supporting tissue of the tumor. So tumor basically has two parts. One is parenchyma and other one is stroma. Parenchyma defines the actual characteristics of the tumor, while stroma is a supporting tissue which support the growth of the tumor. And the names of tumor mostly are derived from the cells making the parenchyma of the tumor. For example, in case of benign tumors, word OMA is added to the cell type which makes up the parenchyma. For example, if it is arising from fibroblast, then OMA is added to the fibro word and it comes about fibroma. And if it is arising from cartilage, then it becomes chondroblast. From chondroblast, it becomes chondroma. And if it is arising from lipid cells, then it becomes lipoma. Okay, so word OMA is added to the name of the cells which make up the parenchyma. In case of fibroblast, fibroma; chondroblast, chondroma; lipoblast, lipoma. Okay, and if a tumor shows or makes gland-like structure or has a glandular origin, then word adenoma is used. Okay, for example, if a benign tumor is arising from pituitary gland, okay, and pituitary we know that is a glandular structure, then it will come about as pituitary adenoma due to its glandular structure. And if a tumor makes finger-like projection on a surface, then word papilloma is used. Papilloma is epithelial tumor which makes finger-like projection on a surface. And if a tumor makes finger-like projection inside mucosal surface, then word polyp is used. For example, colonic polyp or nasal polyp, you can say. Nasal polyp are basically inflammatory. However, they can also be of neoplastic origin. And sometimes a word, if a tumor arising in a hollow cystic organ, for example, in case of ovaries, word cystadenoma is used to show its cystic nature. However, this nomenclature is not generalized. There are many exceptions to this nomenclature, and all the tumor does not fit into this current nomenclature. So now we come toward the malignant tumors. So in case of malignant tumors, the tumors which arise from mesenchyme or have mesenchymal origin, word sarcoma is used with them. For example, having sarcoma is basically a bone tumor. Okay, and liposarcoma, if tumor arises from lipid or fat cells, then a lipoblast. In case of, if it is a benign tumor, then word lipoma is used. And if it is a malignant tumor, then liposarcoma is used. And if it is arise from skeletal muscle cell, then rhabdomyosarcoma word is used. If it is arise from cartilage, chondrosarcoma is used. Okay, so if benign tumor arises from chondroblast or cartilage, it is called chondroma. If a malignant tumor arises, it is called chondrosarcoma. Okay, and if benign tumor arises from lipid cell, it is called lipoma. And if malignant tumor arises from lipid cell, it is called liposarcoma. However, if a tumor is from epithelial origin, okay, tumor originating from epithelium are called carcinoma. For example, tumor arising from the skin include squamous cell carcinoma, basal cell carcinoma, okay, and they can be endometrial carcinomas and ovarian carcinomas and so on. However, in a very similar way, the tumors which make gland-like structures here are also called adenocarcinoma. For example, a tumor arising in the stomach is called gastric adenocarcinoma. Okay, and the tumor arising in colon is also labeled in the very similar way. And the tumor which forms squamous cell is called squamous cell carcinoma. However, this classification is not so much simple. This nomenclature is not so much simple. There are tumors which does not follow these guidelines and they are named accordingly. However, we move towards some special type of tumors which are called mixed tumors. Some type of tumors are called mixed tumors, and these tumors have multiple tissues in them. For example, pleomorphic adenoma of the salivary gland is an example here. This tumor has epithelial component as well as fibromoxide stroma. And moreover, another example here is teratoma. This is a tumor which arises from the teratoma is basically a tumor which arises from ovaries as well as testes, and it has component from all three germ layers, and the cell here produce a different tissue component. For example, it can have bone, it can have cartilage component, it can have hairs, it can have epithelial component, so on. And we move toward some special terminologies here. One of them is hematoma, and other one is choristoma. Okay, So hematoma is basically disorganized epithelium inside a tissue. For example, a disorganized epithelium arising inside the liver is called hematoma. Disorganized epithelium of the liver is called hematoma, which arises inside the liver. It means that it is arising in the same tissue. However, if an epithelium arises in abnormal place, or tissue grows in its abnormal location, it is called choristoma. For example, if a pancreatic tissue grows inside the GI tract, it is called choristoma. Okay, and some tumors have we already have discussed that does not fit into this classification. For example, seminoma is a testicular tumor, seminoma, which does not fit into this classification. In the same way, dysgerminoma is an ovarian tumor of a female genital tract, and so on. So this classification is not general. There are many tumors that does not fit into this classification. Okay, so it is a general overview. Many tumors does not fit into this kind of classification, and you will find in the course of pathology that the nomenclature of the tumor is a complex thing which cannot be summarized in so easy and so small or summarized way. In this video, we are going to discuss different characteristics of the benign and malignant neoplasm. So basic three properties which differentiate benign and malignant neoplasm are differentiation and anaplasia, local invasion, and metastasis. So we are going to discuss them one by one. So first of all, we move toward differentiation and anaplasia. What does differentiation mean? Differentiation means that a tumor or cell is committed to perform specific function. For example, cartilage performs the supportive function inside the body, and it is made up of chondrocytes. So chondrocytes are the differentiated cells which are destined to perform the function of support. At the very same time, a bone is composed of osteocytes, and osteocytes are also differentiated cells which are destined to perform the function of support inside the body and formulate the bone. So osteocytes are the differentiated cells, and these arise from osteoblast. Chondrocytes are the differentiated cell which come from chondroblast. So this is the concept of differentiation. So what is anaplasia? Anaplasia means lack of differentiation. So it is literal meaning of anaplasia or backward formation. So anaplasia is also regarded as de-differentiation. De-differentiation. It means that a cell was differentiated and later on it led to the undifferentiation or de-differentiation. This is called anaplastic change, and the tumors which lack differentiation are called anaplastic tumors. So what does it mean that a tumor is anaplastic? It means that tumor cells are not differentiated, are not committed to perform the specific function. A well-differentiated tumor is a tumor in which cell resembles to the original cells, or the cells from which tumor arise. For example, a chondroma. For example, we take an example of chondroma. Chondroma is the benign tumor of cartilage. So in the chondroma, cell will resemble to the chondrocytes or the cartilage forming cells, and in lipoma, cell will resemble to the lipid cells or adipocytes. Okay, so these are the examples of the differentiated tumors. However, in undifferentiated or anaplastic tumors, cells don't resemble to their original cells, and when there is more anaplasia, there is more malignant potential. Well-differentiated tumors are mostly benign tumors, or you can say otherwise, benign tumors are mostly well-differentiated tumors. However, the malignant tumors can be differentiated and can be anaplastic. Anaplasia is the characteristic of malignant tumors. You can say a well-differentiated tumor can be benign as well as malignant. However, an anaplastic tumor is always malignant. Okay. So what are the different characteristics which an anaplastic cell shows or anaplastic tumor shows? It shows pleomorphism. What does it mean? Pleomorphism means different cells have different size and shape. For example, supposedly we have a well-differentiated tumor. In well-differentiated tumor, all cells will be of equal size and same shape. However, when there is pleomorphism, this shape will change into kind of irregular cells. Okay, some cells will be large, some will be small, and so on. This is called pleomorphism. Cells have different size, different shape. then cell will have nuclear abnormalities. What does it mean? It means that their nuclei will be showing increased size. Okay, size of nucleus will increase and the nucleus will almost fill the cytoplasm. So this property is called increased nucleus to cytoplasm ratio. It means that nucleus will be increasing in size and it will fill most of the portion of cytoplasm. So there will be abundant mitotic figures. It means that rate of mitosis will increase, and we know that in normal mitosis cell arrange at the chromosome arrange at the two poles of the cell at the end of anaphase, and then these two cells divide. However, in this cell, instead of these two poles, there can be three pole, in which chromosome may move to three poles. Okay, or there can be four poles and so on. So these are the different nuclear abnormalities which anaplastic tumors show. And there increased nuclear to cytoplasm ratio. There are abundant mitotic figures, or abnormal mitotic figures, and there are you can say abundant nucleoli and so on. And these tumor can also lead to the formation of giant cell. Giant cell are basically in large cell, you can say a cell like this. This is a giant cell, multinucleated giant cells. Okay, and they show atypical mitosis, and there is loss of polarity. Loss of polarity means they become oblivious of each other and don't show a regular growth pattern. Instead, they grow randomly. For example, if a tumor arose from a gland-like structure and these tumors lost their polarity, and instead of forming gland, they begin to grow in the form of sheets and so on. So this is basically pleomorphism, which the malignant tumor show the correct. Next, we move on towards dysplasia. What is dysplasia? Dysplasia is basically disordered proliferation of the cells. It means that the normal proliferative pattern or the growth pattern of the cell is damaged, and this dysplastic cell or dysplastic tissue also shows pleomorphism, which is different in size and shape of the cells, and abnormal nucleus, increased nuclear to cytoplasm ratio, and abnormal location of mitosis. What does it mean? Supposedly, we take an example of stratified squamous epithelium. What happens in stratified squamous epithelium? Basal layer are basically cuboidal, low columnar, you can say, and these cells, when they move on above, these cells are gradually replaced by squamous cells, and then these squamous cells also lose their nuclei, and top layers are basically keratin layer. So in this way, there is stratified squamous epithelium. So what happens in dysplasia? In this normal epithelium, the cell division is limited to the basal layer. Okay, cell divide at basal layer, and these new cell formed move aboveward in upper layers. However, in dysplastic change, what happens? This cell division is disrupted, and cell begin to divide in the all layers of cell. Supposedly here also cells are dividing, here also cells are dividing, and the cells are also showing pleomorphism, size is disrupted, normal growth pattern disrupted, and this is a dysplastic epithelium. Okay, so this is basically dysplasia, which is disordered proliferation of the cells. And when these dysplastic changes cover entire thickness of the epithelium, when they cover entire thickness of epithelium, it is termed as carcinoma in situ. What does it mean? It means that this carcinoma is limited to the tissue and it has not invaded through the basement membrane. This is basement membrane. So as long as carcinoma has not invaded the basement membrane, it is called in situ carcinoma in situ. However, if these cells cross this basement membrane and spread downward away from the basement membrane, then it is invasive carcinoma. It is not carcinoma in situ in that case. And as long as these dysplastic changes are limited to some portion of epithelium, not the entire thickness of epithelium, they can revert back, as we will study in the cervical carcinoma. However, when they become carcinoma in situ and cross the basement membrane, they move toward aggressive course. Okay, so this was the basically differentiation, anaplasia and dysplasia. Now we move toward the next characteristic difference between benign and malignant tumors, which is local invasion. So what happens? Benign tumors are basically slow growth tumors. They are well differentiated, and when they are growing slowly, this is positive tumor mass, and it is slowly growing, increasing in size. It exerts pressure on the surrounding tissues, and these surrounding tissues become hypoxic. When they become hypoxic, fibroblasts accumulate here and form a capsule-like structure. So these benign tumor become encapsulated, and they become encapsulated. The result, they are well movable and freely movable tumors, well encapsulated, well differentiated, movable tumors. However, it is not always true. Some tumors are not encapsulated, but they are also benign. For example, hemangioma. This is a non-encapsulated benign tumor. However, a leiomyoma of uterus, it is a encapsulated benign tumor. Okay. However, the malignant tumors are mostly non-encapsulated. Even if a malignant tumor appears to be encapsulated, it can be a deception. It can be a deception. How? Because supposedly this was a malignant tumor, and you imagine that this is a tumor, and this is a tumor here, and this bluish color appearing, suppose that this was a capsule. But in malignant tumor, what happens? In most of the cases, small crab-like extensions are going out of the capsule, and these extensions are basically showing local invasion. So in case of malignant tumor, it is always necessary when you surgically excise the tumor, you should examine the margin of the excised tissue microscopically to imagine to observe these crab-like extension. If there are extension, then more tissue should be excised to until the surgical margin are clear of the or clean of these crab-like extensions. So it is the local invasion. Local invasion is also basically a property of malignant tumors, not of benign tumors. And next one is the metastatic spread or metastasis. So metastasis is basically characteristic of the malignant tumors. Benign tumors don't show metastasis, and the potential of a tumor to metastasize is directly proportional to its degree of anaplasia and tumor size. Greater degree of anaplasia, greater metastatic potential. Greater tumor size, greater metastatic potential. Okay, and some malignant tumor, however, don't show metastasis. However, they spread locally. For example, basal cell carcinoma of skin, CNS tumors. It is either locally destructive, locally expand and destroy local tissue, but don't show metastasis. Now we come toward principal route of metastasis. How metastasis occurs? Metastasis basically occurs through different three main routes. One is seeding of the body cavities, other one is lymphatic spread, and the third one is hematogenous or spread through blood. So seeding of body cavities occur in case of mostly ovarian carcinoma or ovarian cancer, which seed the peritoneal cavity. And the seeding of body cavities also occur in case of medulloblastoma, which is CNS tumor, and ependymoma, which spread to the ventricles of the brain, and they can also show drop metastasis. And you will study these tumors next one in the respective chapters or respective systems. And next we move toward lymphatic spread, and lymphatic spread is mostly shown by carcinomas. And carcinoma, though, is basically epithelial tumors, and the hematogenous spread is mostly shown by sarcomas, which are mesenchymal in origin. So this is not a you can say hard and fast rule. Carcinomas can also spread by blood, and sarcomas can also show lymphatic spread. Okay. So in carcinoma, we should be knowing two terminology. One is sentinel lymph node. What is sentinel lymph node, and what is skip metastasis? Sentinel lymph node is basically first lymph node draining the tissues. Okay, supposedly in breast cancer, breast carcinoma mostly occurs in the upper outer quadrant of the breast, and it mostly goes into axillary lymph node, and first axillary lymph node which comes into the pathway and cancer cell gets settled there. It is called sentinel lymph node. And what is skip metastasis? Skip metastasis means sometime cancer cells, instead of settling into the first lymph node, skip it and move to the second one or subsequent lymph node. This mode of metastasis is called skip metastasis, and you can observe both kind of metastasis in case of malignant tumors. And these lymphatic spread mostly occurs to the region where lymph nodes, region of the lymphatic drainage of particular tissue. And it is not always true that the lymph node draining a particle site of cancer are always be increased in size due to metastasis. Sometimes they may be increased as a result of inflammatory reaction going on there due to cancer antigen coming from or cancerous debris coming into the lymph nodes. And the sarcomas mostly spread into the blood vessels and by blood, and this mode is commonly seen into the different body tissue tumors we will study on individually in the different systems. However, we discuss the principal site of their settlement. They mostly settle into the liver and lungs. For example, the sarcomas which are get drained into the cable blood vessels, which mostly portal veins, mostly which goes into the liver, and the sarcomas which come into the cable blood vessel, they go into the heart, and from heart they move to the lungs. So they basically settle into the first capillary bed they encounter, which is mostly liver or lungs. Okay, so supposedly a sarcoma came from a carcinoma, cancer, or tumor originating from the GIT tract get involved into the blood vessels of the GIT, which drained into the liver, and its carcinoma metastatic tumors or cell get settled into the liver. And the very same way a cancer got invaded the vena cava, and it goes into the heart, and from heart it gets settled into the lungs, where encoding the first capillary bed. Okay, so these are the different site of settlement. However, it is not always hard and fast rules about the carcinomas. Cancer don't follow the rules, sadly, and they can show a deviation from all the rules settled by human beings. In this video, we are going to discuss different factors which are responsible for the carcinogenesis or the development of neoplasm. So different factors that contribute include obesity. Obesity is found to be linked to the various type of cancers, and smoking is the principal cause of the lung cancer, and alcoholism is also linked to the different kinds of cancer, including hepatic carcinoma, including gastric carcinoma, and infection due to different carcinogenic viruses as well as HIV also associated to the development of cancer. And occupational exposure to different metals and different agents can also cause cancer. For example, arsenic, which is the principal metal the workers of the electrical industry and alloy industry are exposed to, and this arsenic can lead to the skin malignancy as well as lung malignancy. Moreover, asbestos, which is basically a construction material, and the construction workers are exposed to asbestos, and it can lead to lung carcinoma as well as mesothelioma. And beryllium, which is a metal used in the missile, which is a chemical or element used in missile fuel as well as space vehicles, and it can also lead to the development of lung carcinoma. So different kind of occupational exposure can also lead to development of carcinoma. And genetics is also linked to cancer development. For example, BRCA1 mutation are basically involved in the medullary carcinoma of the breast, and radiation exposure can also cause to cancer. For example, radiation exposure in children can lead to the development of osteosarcoma, and inflammatory diseases are also linked to the development of cancer. For example, inflammatory bowel disease can lead to the development of colorectal carcinoma. Pancreatitis can lead to the development of pancreatic carcinoma. Moreover, age is also linked to the cancer. For example, cancers mostly occur in the older age people, because as a person ages, there is more and more accumulation of the mutation in the DNA until a stage reaches when the cells break their barriers of the controls and continue to divide at their own, leading to the development of cancer. Moreover, the down regulation of the immune response is also a factor for carcinogenesis in old age. However, it is not always true, as many cancers also occur in children. For example, having sarcoma as well as osteosarcoma, bone cancers, CNS tumors, leukemias, and they also show their prevalence in the children. So cancer usually don't follow the rules set by human beings. Okay, so different principal factors. These factors include you can say environmental as well as genetic factors which contribute to the development of cancer. So cancer usually arises from some of its precursor lesion. So what is precursor lesion of the cancer? It is basically a localized defect in the differentiation of the cell. Localized defect in the cellular differentiation occur in some tissue, and this localized defect can progress to the cancer. So it is always advisable, if there is a precursor lesion of cancer, it should be removed or treated accordingly to decrease the risk of cancer's development. Different precursor lesion exist for different cancer. For example, in case of smokers, their epithelium of the respiratory epithelium shows squamous metaplasia. It means it is replaced by squamous epithelium and dysplasia or dysplastic growth, which can lead to the development of lung carcinoma or bronchogenic carcinomas. Moreover, endometrial hyperplasia and endometrial dysplasia is a characteristic in high estrogen exposure, which can be a part of estrogen replacement therapy and so on, and it can lead to the development of endometrial carcinoma. Moreover, leukoplakia, which are the lesions, epithelial lesions due to chronic irritation, they can be at oral mucosa or gentle skin or so on, and they can also lead to the development of carcinoma or squamous cell carcinoma. And villous adenoma are basically chronic polyps, and these chronic polyps also have the potential to develop into the colorectal carcinoma. So there are different precursor lesions which can transform into the cancers, and different precursor lesions have different potential to transform into the cancer. So these are the different factors and precursor lesions for the development of carcinomas. In this video, we are going to discuss about cancer genes as well as different genetic mutations which lead to the development of tumors. So in cancer gene, first gene of the great importance is oncogene. Oncogenes are the genes which lead to the increased cellular production. These oncogenes are basically derived from proto-oncogenes. So what are the proto-oncogenes? Proto-oncogenes are basically genes which normally regulate the cell division. However, if there is some mutation in proto-oncogenes, they get converted to oncogenes, and they then lead to the increased production of the cells. One common example of the oncogene is RAS pathway, and which is involved in the cellular signaling, which control the cell cycle or cellular production. Okay, so oncogenes are mostly the genes which are involved in increasing the cellular production or increasing the rate of the cell cycle, and they are derived from the proto-oncogenes. Proto-oncogenes are the normal genes regulating the cell cycle. When they get mutated, they get converted to oncogenes, and common example of this is RAS pathway, which we will study later on. When this pathway get amplified, it leads to the production of tumors. Next genes are tumor suppressor genes. These are the genes which when they detect any kind of cellular defect or cellular mutation, they lead to the arresting of the cell cycle. However, when they get mutated, they lead to the production of tumors. One common example here is retinoblastoma, which is also called governor of cell cycle, and TP53, which is called guardian of genome. Retinoblastoma regulate the cell cycle. If it encounters some imbalance in the cell cycle going on or some kind of mutation, it arrests the cell cycle. That's why it is called governor of cell cycle. However, TP53 is also guardian of genome. This guardian of genome is basically it is basically arranged in such a way that if there is some kind of mutation inside the DNA, it identifies that mutation and it upregulates the DNA repair mechanisms. Okay, so if the damage is repaired, then it continues the cell cycle normally. However, if the damage is beyond repair, it either arrests the cell cycle completely or lead to the apoptosis of the cell. So it is called guardian of genome. These are tumor suppressor genes. So if tumor suppressor gene get mutated, they can also lead to the increased production of cell and increased production of tumors inside the body. Next gene involved here are apoptosis regulators. We know that apoptosis is the regulated cellular death, and this apoptosis is basically regulated by a delicate balance between pro-apoptotic members and anti-apoptotic members. So most common pro-apoptotic members are BAC and BAX, and anti-apoptotic members are BCL2, BCLXL, and MCLI. Okay, so when pro-apoptotic members are active, for example BAC and BAX, they lead to the cellular destruction or cellular death by process of apoptosis. However, when anti-apoptotic members are active, they lead to the sustained cellular growth and sustained cellular survival. What happens in cancer cells? In cancer cell, the activity of BAC and BAX is down-regulated. However, anti-apoptotic factors are up-regulated. And when they are up-regulated, they lead to the continuous cellular survival, and cell become resistant to the apoptosis. Next are the genes which control the interaction of the cancer cell with other cells. We know that in our body, immune system targets the abnormal cells. So if there is some tumor cell, cytotoxic T cell identify that cell and lead to its destruction. However, cytotoxic T cell is functioning by identifying MHC1 protein on the tumor cell. What happens? Tumor cells don't regulate MHC1 protein, and when they don't regulate this protein, they become invisible to the immune system and they evade the immune response. In this way, these four genes basically oncogene, tumor suppressor gene, apoptosis regulator, and interaction regulator lead to the development of cancer or tumors inside the body. So what are different kind of mutations which can happen and lead to the carcinogenesis? Two principal classification of mutation are the driver mutation and passenger mutation. What are driver mutation? Driver mutation are basically principal mutation that directly alter the cellular activity. They directly alter cellular activity. However, passenger mutations are the mutation which does not directly alter the mutation, but they come for a ride along with driver mutation. You can say these are the additional mutation along with driver mutation. So what is the importance of passenger mutation? This passenger mutation basically help us in two ways. Help us in one way. What happens? We know that carcinogens are the agent which lead to the genetic damage. So if we suspect that a particular carcinogen is causing DNA damage or not, we identify the damage along the different parts of the DNA sequence. So this passenger mutation help us to quantify whether this carcinogen is actually causing DNA damage or not. Moreover, this passenger mutation is also involved in the drug resistance of the tumors. If a tumor become drug resistant, most probably it will be having relative passenger mutation which are conferring it a drug resistance. Driver mutation are mostly concentrated into the actively involved genes or tumor genes. However, passenger mutation are scattered throughout the genome. So what are different mutations which may occur in the genome or DNA sequences which can lead to the carcinogenesis? They can be grouped into different types, which is point mutation. Point mutation is basically mutation in single amino acid. A single amino acid may be replaced by some other amino acid. So this point mutation are involved in the amplification or overactivity of a RAS pathway, which make the tumor cell self-sufficient of growth signal, or they can lead to the inactivation of TP53 pathway. And then the gene rearrangement. What are gene rearrangement? These are basically a process in which a segment of chromosomes, positively this is a chromosome and this is another chromosome. What happens in gene rearrangement? One part of this chromosome can move to this one, or this chromosome can move to this one. So these are genetic rearrangement which can lead to the production of tumors. For example, translocation 14-18 occur in case of follicular lymphoma, translocation 8-14 occur in case of Burkitt lymphoma, and translocation 9-22 occur in case of CML or chronic myeloid leukemia, which lead to the BCR-ABL fusion, which can we can look at it here in the diagram in the book. Let me show you. So this is basically chromosome 9 and this is chromosome 22. What is happening here? This is ABL oncogene and this is BCR locus. So what is happening? Gene from here, it is getting translocated to here, and it is leading to the BCR ABL fusion and producing hybrid gene, which lead to the oncogenesis or tumor production. Okay. More translocation example here is 8-14, T8-14. Here you can see this is the IgG gene here, and this is MYC oncogene, which is getting translocated to here, and it can lead to the MYC oncogene and IgG locus, and it leads to increased MYC production, which lead to the increased expression and increased expression of pro-growth gene, which lead to the carcinogenesis. So this is the translocation example, which we will study also in the special pathology portion of the systems. Moreover, deletions can also lead to the carcinogenesis. For example, if there is some deletion in retinoblastoma gene, it can lead to inactivation of retinoblastoma, or TP53 inactivation can also occur by deletion of the some amino acid or some part of gene. Moreover, amplification can also lead to the carcinogenesis. For example, N by MC gene amplification lead to the neuroblastoma development. If, for example, if there is oncogene and it gets amplified, on amplification it's more copies are produced, and when more copies are produced, there is more and more growth of cell, and there is more and growth of cell, there is more and more tumor production. So amplification also contribute to the carcinogenesis. Moreover, aneuploidy also contribute to carcinogenesis. What is aneuploidy? It is basically chromosome number in the cell, which is not the copy of applied number or 23 number of chromosome. So what happens in carcinogenesis? Mostly the genes which increase cellular growth are retained, however which suppress cellular growth are decreased in case of aneuploidy. And what happens when tumor suppressor genes are decreased and tumor promoting cell are increased or oncogenes are increased? They lead to the increased cellular production. Next, microRNAs also play a role in carcinogenesis. MicroRNAs can lead to the decreased gene expression by cleaving messenger RNA or by altering the process of translation, and due to which they are called onco-IRS, and these in this way they can lead to the down regulation of the tumor suppressor gene. When they don't regulate tumor suppressor genes, it lead to the oncogenesis or production of carcinomas. Moreover, they can also, if microRNA don't regulates the oncogenes, and supposedly if microRNA don't regulate oncogene normally, and this microRNA in itself don't regulate it. When itself will be down regulated, oncogene will be up regulated, and can also lead to the production of cancer. So it can contribute to carcinogenesis by down regulating tumor suppressor gene or down regulating itself and promoting the up regulation of oncogenes. Moreover, epigenetics also contributes to the cancer development. What is epigenetics? It is basically a set of heritable changes in gene expression without changing DNA sequence. It means that these are the changes which are inherited and passed to the offspring cell. However, these are not the changes in the DNA sequence. Instead, these changes manifest themselves in the form of histone modification or changes in DNA methylation. You know that if a part of DNA is hypermethylated, expression of its genes is down regulated. So supposedly, if in epigenetic change tumor suppressor genes become hypermethylated, when they will become hypermethylated, their expression will be down regulated, and when their expression will be down regulated, it can lead to the production of tumors. So in this video, we are going to discuss the different hallmarks of the cancer. So what are the different hallmarks? As we previously discussed that hallmarks are basically a set of characteristics which cancer cells attain, which help them to grow continuously. So what are these specific characteristics which different cancer cells attain? These characteristics include self-sufficiency in growth signals. It means that they no longer depend upon the growth signals for their growth. They become self-sufficient, or they become able to synthesize their own growth signals. So they become self-sufficient in growth signals. They become insensitive to the growth inhibitory signals. They no longer respond to the inhibitory signal. As a result, their growth continues. They alter their cellular metabolism to survive their own metabolic needs, and they evade the apoptosis. As we know that the cells which have a deranged genetic setup are subjected to the apoptosis. However, the cancer cell rearrange themselves in such a way that they avoid the process of apoptosis. They gain limitless replicative potential. We know that in a normal cell there is telomerase which gets shortened with every division, and as it gets shortened, its replicative potential of the cell declines. However, the cancer cell make rearrangement in their telomerase as well and get limitless replicative potential. Moreover, they synthesize factors which lead to the sustained angiogenesis, or there is formation of new blood vessels which supply them the blood and nutrients for their survival. Moreover, they invade the surrounding tissue, and they show the process of metastasis and spread to the distant sites. Moreover, they also evade the response of immune system, and they prevent themselves from the cytotoxic T cell by regulating their expression of the MHC protein, or major histocompatibility complex proteins. Okay, so we begin with the first factor, which is self-sufficiency in growth signals. Okay, so how the normal cellular process works, a normal cellular growth process works. Imagine this is a cell here, and this is the nucleus, and in nucleus there is the genetic material, and here are the receptors, you can say growth receptor outside on the plasma membrane. And a growth factor comes, supposedly this is the growth factor, it binds here, and its binding lead to the downward cascade of the signaling, and different signaling molecules are produced, and these signaling molecules go to the nucleus, and when they go to nucleus they act as a transcription factor, and they lead to the translation of different proteins and different kind of messenger RNAs and so on, which synthesize different material for the cell cycle, including the different organelles and different proteins, and also initiate the replicative process of the DNA, and ultimately leads to the cellular division, in which this cell there is arrangement at the different poles of chromosome, and there is then cell division, and two daughter cells are produced. Okay, so in this way normal growth process works. So what are the different requirements here for the cell growth? There is a requirement of the growth signal. Okay, there is a requirement of signal receptor, and there is also requirement of a downward signaling pathway. So normal growth of cell requires a receptor, a growth signal or growth factor, and downward signaling pathway to promote the cellular growth. Tumor cell becomes self-sufficient in all these pathways in one way or other. For example, common growth factors are platelet-derived growth factor, or epidermal growth factor, or transforming growth factor, or TGF alpha. So what happens? Tumor mutates itself in such a way that it begins to synthesize this factor on its own. So when it begins to synthesize this factor on its own, these own or self-synthesized factors start stimulating this receptor and then activate downward signaling pathway and lead to the cellular division. However, if it does not synthesize it on its own, it reacts with stroma in such a way that it stimulates this stroma to manufacture these growth factors, and in one way or other, either it begins to synthesize on its own, or it stimulates the stroma to synthesize these growth factors, which in turn stimulate the cancer cell and lead to its growth. Moreover, it also upregulates its receptors. Okay, for example, common classic example here is HER2 new receptor here. This is the HER2 receptor, which is very common in the breast carcinoma. Okay, in breast carcinoma, this receptor is present in some types of breast carcinoma. This is amplified, and this is a growth factor receptor. Okay, so when it is amplified, it leads to the increased signaling and increased cellular growth, and therefore there are certain treatment therapies which target this receptor, and by blocking this receptor, these therapies don't regulate the growth of breast carcinoma. So it was about synthesizing growth factors and increasing growth receptors. The third way is increasing the signaling cascade or making it self-sufficient. Okay, so for that we will be discussing the RAS pathway. RAS pathway, which is involved in the signaling commonly, and its mutation is common in different type of cancer, and we will be discussing this RAS pathway in the next lecture. Hi there, we resume our lecture on the self-sufficiency of the growth signals, and in this lecture we are going to discuss about the RAS or RAS pathway. So what was the RAS pathway? Basically, RAS is a you can say molecule or protein which is involved in the signal transduction of the growth factors. Supposedly, this is the cell membrane here, and here is the growth factor, growth receptor here, and a growth factor comes which gets attached to this growth receptor, and when growth factor get attached to this receptor, on the inside projection, let's make it a bit longer, and this growth receptor has its projection inside, and it is in association with the RAS protein. Supposedly this is the RAS protein, and this RAS protein has a binding site here, binding site to bind GDP or GTP. Okay, so it binds here normally molecule of GDP. When it is bound to GDP, it is inactive. Okay, in inactive state it is bound to GDP. However, when a growth factor comes and activates the growth receptor, this RAS, what it does, it replaces this GDP with GTP. It binds to GTP, then RAS gets bounded by GTP, and when it gets bound to GTP, it becomes activated. When it becomes activated, it leads to the downward cascade of the signals, and this cascade of signals is manifested in two different pathways. Okay, one is PI or phosphatidylinositol 3 kinase pathway, and other one is mitogen activated protein kinase pathway. Okay, phosphatidylinositol 3 kinase pathway, and other one is mitogen activated protein kinase pathway, and it leads to the production of different transcription factors, and these transcription factors move inside the nucleus. Supposedly this is the nucleus. It should be formed rounded, and here are the chromosomes. Okay, and these pathway lead to the formation of transcription factor, and this transcription factor move to the DNA and lead to the translation of the transcription and translation of the MYC protein, and this in turn leads to the increased cellular growth and increased cellular division. Okay, so this was the RAS pathway. So what tumor cell do to this pathway? Basically, when this RAS gets attached to GTP, it becomes activated. However, it has an intrinsic GTPase activity. This intrinsic GTPase activity cleaves GTP back to GDP, and when it is cleaved back to GTP, RAS pathway becomes inactive. So it is transiently activated only when growth factor binds here. When growth factor binds here, RAS binds GTP, it becomes activated. Then GTPase activity of RAS inactivates it by cleaving the GTP back to GDP and releasing the phosphate. However, moreover, there are some other proteins which are called GTPase activating proteins. These GTPase activating proteins further activate the GTPase activity here. Okay, so they also lead to the down regulation of the RAS pathway. So what cancer cell do? Cancer cell accumulate a mutation, and this mutation is either at the binding site of GTP or affecting the GTPase activity. So in both cases, what happens? RAS gets bounded or remains bounded to the GTP in the activated state. So either it is not able to cleave the GTP or it is not able to release GTP, and in both cases it becomes activated. Moreover, GTPase activity in some cancer, GTPase activating proteins are also down regulated, due to which RAS activity is increased, and in both cases this pathway becomes overactive, and when it becomes overactive, there is increased signal transduction downward, and there is increased transcription and translation, and there is increased cellular division. We see this diagram from the book also here, and you can see this is the RAS pathways. You can appreciate here. So here was the growth factor, and there was the receptor, and it bound to RAS, and then RAS got activated by binding to GTP, and this active RAS lead to the two pathway. One is RAF or MAPK pathway, which is mitogen activated protein kinase, which is a transcription factor, and other is PI3 kinase pathway, which lead to the production of transcription factor mTOR, and you need not to go into the details of these transcription factors, just names are enough, and these transcription factor lead to the activation of MYC protein, which led to the cell cycle progression. Okay, so its mutation are found in different types of cancer carcinomas. For example, GTPase activating protein mutation is found in the cancer which is called neurofibromatosis type 1. In the very same way, tumor suppressor gene PTEN is the inhibitor of PI3 kinase pathway, and its mutation is also found in certain leukemias and other cancers as well. So in this video, we are going to discuss retinoblastoma gene, or the governor of cell cycle. So previously in the hallmarks of cancer, we discussed that the cancer cell or the tumors become insensitive to the growth inhibitory signals. So retinoblastoma is basically a tumor suppressor gene. It is a tumor suppressor gene, or you can say it provides growth inhibitory signals to the cells. However, the cancer cell become insensitive to the retinoblastoma. So retinoblastoma is the first discovered tumor suppressor gene, and in order to mutate its function, its both allele should be dysfunctional, which is called Knudsen two-hit hypothesis. This hypothesis states that if there is one functional allele of retinoblastoma, retinoblastoma function will be normal. However, when both alleles are lost, then its function will be abnormal, and this loss of allele can be sporadic, and both alleles can be lost sporadically without any genetic predisposition. However, in the individuals which have a genetic predisposition to retinoblastoma, their one allele is mutated, and this allele is located on the chromosome 13. Or so in familial cases, the one allele is mutated already, and the sporadic mutation of the second allele leads to the development of retinoblastoma as well as other carcinomas linked to the retinoblastoma gene. So as it is evident that one functional allele is sufficient to cause its normal functioning, it follows the autosomal dominant pattern of inheritance. Okay. So retinoblastoma gene does not only cause retinoblastoma, the tumor of the retina, but it also causes the other tumors. For example, it has involvement in breast carcinoma, it has involvement in osteosarcoma, which is bone tumor, and so on. So it is also involved in the small cell carcinoma of the lungs. So it is involved in multiple carcinomas. So it is one of the principal tumor suppressor gene which gets mutated and leads to the development of multiple kinds of tumors and cancers. Okay, so how does it function? Retinoblastoma exists in two forms. One it is active form and one it is inactive form. It is active when it is hypophosphorylated, or you can say when it is not phosphorylated or hypophosphorylated, it is active. And in its active state, what does it do? It stops cell cycle. As it is a tumor suppressor gene, so when it is in activated state, it stops the cell cycle. And how does it stop the cell cycle? It stops cell cycle at the G1S checkpoint. And this G1S checkpoint is very, very important checkpoint of the cell. We know that cell cycle processes through the G1 phase, and then S phase, and then G2 phase, and then comes the mitotic phase. Okay, so this G1 to S transition is very, very important, because when cell enters the S phase, it is committed to divide. So as the cell is G1 phase, it can go into G0 phase as well. If the cell is abnormal, it can enter into G0 phase and can lead to the apoptosis, as well as can stay in the G0 phase for indefinite time. So when it has entered to S phase, it will divide always. Okay, so this checkpoint is highly important, and retinoblastoma regulates this checkpoint. This transition from G0 to S phase requires a complex. G0 to S phase transition requires a protein complex which is called cyclin E and cyclin dependent kinase 2 complex, or cyclin E CDK2 complex. This complex is mandatory for G1 to S transition. What retinoblastoma do? When retinoblastoma is hypophosphorylated and it is active, it stops G1S transition by holding E2F family of the transcription factor. These are the specific transcription factor which lead to the translation and production of cyclin E proteins. Okay, so activated retinoblastoma stops G1S transition by holding E2F family of transcription factor. When it holds this family of transcription factor, cyclin E is not produced, and when cyclin E is not produced, this complex is not formed, and when this complex is not formed, G1S transition does not occur. Okay, so in its activated form, it leads to the down-regulation of cyclin E and stop the cell cycle. However, if it is phosphorylated or hyperphosphorylated, use the term hyperphosphorylated, then it becomes inactive. When it becomes inactive, E2 transcription factor is released, and this E2 transcription factor goes to the nucleus, lead to the production of cyclin E. Cyclin E and CDK2 complex is formed, and G1S transition occurs. So remember, retinoblastoma is a tumor suppressor gene. When this tumor suppressor gene is active with its hypophosphorylated form, it stops G1S cycle. How it stops? It stops by holding E2F transcription factor, and when E2F transcription factor is not available, cyclin E is not produced. When cyclin E is not produced, cyclin E CDK2 complex is not formed, and this complex, when it is not formed, G1S transition does not occur. Okay, so when it is inactivated or hyperphosphorylated, E2F transcription factor is released, cyclin E is formed, and CDK2 and cyclin E complex is formed, and G1S transition occurs. So it is the basic mechanism through which retinoblastoma works. Moreover, it also it is also interlinked to the DNA deacetylase enzyme as well as methyl transferase enzyme, which lead to the methylation and the changes in the promoter sequence of the A2F transcription factors. And even if some amount of A2F transcription factor is produced, the retinoblastoma makes the promoter insensitive of this transcription factor and cyclin is not produced. So it is basically on one side it is holding this transcription factor, and on the other side it is also making its promoter sequence on the DNA insensitive to the transcription factor. So when it becomes activated and when it becomes inactivated. So it becomes inactive when there are growth signals. When there are growth signals which want cell to divide. This growth signal can be in the form of epidermal growth factor as well as platelet-derived growth factor, which are called mitotic growth signals. When a cell receives these signals, what happens? There is upregulation of cyclin D, and when cyclin D is upregulated, it leads to the formation of cyclin D, cyclin dependent kinase 4 and 6 complex. Okay, so when a cell receives growth signals in the form of epidermal growth factor or platelet-derived growth factor, cyclin D is produced, and this cyclin D combines with cyclin D kinase or cyclin dependent kinase 4 and 6, and a complex is formed which is cyclin D K4-6 complex. What this complex does? This complex hyperphosphorylates. This complex hyperphosphorylate the retinoblastoma. It hyperphosphorylates retinoblastoma. When retinoblastoma becomes hyperphosphorylated, what happens? It becomes inactive, and this all process occurs and cell cycle occurs. So growth signal make it hyperphosphorylated. However, the inhibitory signal make it hypophosphorylated, and these inhibitory signals can be in the form of these inhibitory signals present in the form of transforming growth factor beta as well as P53 protein, and there can be other factors as well. Okay, when there are these inhibitory signals, what happen? They activate an enzyme which is called CDKN2A. Okay, these inhibitory signal activate an enzyme which is CDKN2A. Here you can say this is the gene and its product is P16. Okay, this P16 is inhibitory to cyclin D and this complex. Okay, so these inhibitory signals lead to the activation of CDKN2A gene, which whose product is P16 or protein 16 you can say, and it inhibits this complex. And when this complex inhibited, a retinoblastoma remains hypophosphorylated and it is active and it stops the cell cycle. Moreover, there are also a specific gene which is in the form of CDKIs or CD kinase inhibitors you can say, and these CDKIs or inhibitors are also responsible for inhibiting the activity of this complex and phosphorylation of the retinoblastoma. So in this way, basically the activity of retinoblastoma is being regulated. When there are growth signals, it become when there are growth signal, it becomes hyperphosphorylated, and it becomes hyperphosphorylated by cyclin D CDK4-6 complex. And when it is hyperphosphorylated, it is inactive and cell cycle occurs. When there are inhibitory signal in the form of TGF beta or P53 or CDKN2A gene product or CDKI gene product, these inhibitory signal inactivate this complex and it remains hypophosphorylated, and when it becomes hypophosphorylated, it is active, and in this way it is hold the A2F and there is no cell cycle. What happen in case of cancer? In case of carcinoma development or mutation, retinoblastoma becomes mutated either in itself and becomes activated, or there is some mutation in the inhibitor pathway, or there is overactivation of the activation of cyclin D. Okay, so either inhibition or the defect of the retinoblastoma itself, or overactivation of the cyclin D gene, or down regulation of its inhibitors, or there is down regulation of CDK and 2A. All these can contribute to the development of carcinoma. So now we'll come toward the diagram here, which is given in the text here. So you can appreciate if I can a bit zoom here. Okay, zoom is not happening. You can see this is the growth factor in the form of epidermal growth factor and platelet derived growth factor, and this growth factor came, they activated the cyclin D and CDK4, and moreover they also increased the cyclin E and CDK2, and the hypophosphorylated retinoblastoma, and when the hyperphosphorylated retinoblastoma, it released G2F. The G2F bind to DNA and lead to the production of cyclin E, and then the S phase started. However, when came inhibitory signal in the form of TGF, beta and P53 or other, they activated CDK inhibitor P16, and what happened? They got inactivated. Cyclin D and CDK4/6 complex, and retinoblastoma stayed inactive, or it stayed hypophosphorylated or active. And what it happened? It holded A2F gene family, and moreover histone methyl transferase got active and histone deacetylase got activated. And what happened? There was transcription block and G1S transition does not occur. So it was the functioning of retinoblastoma, or the governor of cell cycle. So here you can see these are principal defect site. Defect can be in retinoblastoma, it can be in CDK4, it can be in cyclin D, or it can be in P16, which is the product of CDK and 2A. So different diseases target this retinoblastoma, and different viruses also target this retinoblastoma. For example, human papilloma virus, it produces a E7 protein which bind to hypophosphorylated form of retinoblastoma and prevent it from inhibiting E2. Hypophosphorylated form was active and it usually bind to E2F, but what happened when it bound to E7 protein? It does not bind to E2F, and this pathway there is then transition from G1 to S cycle and cell cycle occurs, so it leads to the production of cancer. In this video we are going to discuss TP53, also known as the guardian of genome. So TP53 is also a tumor suppressor gene. It means that it suppresses the cells which are faulted in any way from growing and dividing. In this way it suppresses the tumor formation. So TP53 is a tumor suppressor gene, and P53 is the protein product of the TP53. So this protein product P53 is basically a transcription factor, and it is short-lived. Its half-life is about 20 minutes, and what happens? It is basically bounded to MDM2 protein, and this protein leads to the destruction of the P53. So what happens when there is some mutation in cell, or cell is suppressed in some way? There is post-translational modification in P53 protein, and this post-translational modification is driven by the product of another gene, which is ATM gene, and this post-translational modification frees P53 from MDM2 and increases its half-life. So what we want to say, P53 is a protein product of TP53. It is a transcription factor. Its half-life is usually 20 minutes, and it is bounded to MDM2 protein, and this protein catalyzes its leads to its destruction. However, when cell is suppressed in some way, or there is some mutation or some DNA damage, what happens? ATM2 gene product becomes active, and it leads to the post-translational modification of P53 protein, and when it becomes modified, it becomes free from MDM2, and its half-life is increased. Okay. So this TP53 is guardian of genome, and it can lead to three fates of cell. It can lead to permanent arrest of cell cycle, which is called quiescence, or it can lead to temporary arrest of cell cycle, which is quiescence, or permanent arrest of cell cycle, which is senescence, or it can lead to the programmed cellular death, which is apoptosis. It can lead to cell to follow one of these three fates, either quiescence or senescence or apoptosis. We previously studied retinoblastoma. Retinoblastoma was responding to external signal, which were either growth stimulatory signal or growth inhibitory signal in the form of epidermal growth factor, or platelet derived growth factor, or transforming growth factor, and so on. However, P53 responds to the internal suppressed signals of the cell. Okay, and it senses any damage to DNA or internal suppressing condition, for example anoxia, etc., and stimulates the either arresting cellular growth or destruction of the cell. Okay, so P53 mediated cell cycle arrest occurs in a way that when there is cellular suppress there is activation of gene which is CDKN1A. This gene becomes active in the suppressed condition, or you can say when there is DNA damage. There is some DNA damage. This DNA damage activates the gene CDKN1A and its protein product is P21. Okay, so its protein product P21, what it does, this P21 basically inhibits cyclin D and CDK complexes, or you can say 4-6 complex, which we studied in the retinoblastoma or RB lecture. So this cyclin D or CDK4-6, what it was doing, it was basically leading the phosphorylation of the retinoblastoma or RB. So when retinoblastoma protein product was getting phosphorylated, it was becoming inactive, and when it was becoming inactive, it leads to the cell cycle or cellular division. However, what happens when cell is stressed or there is some DNA damage, CDKN1 gene become active, its protein product was P21. This protein product inhibited cyclin D and CDK complexes, and when this complex was inhibited, there was no phosphorylation. Normally it leads to phosphorylation, but when it got inhibited by P21, there was no phosphorylation, and when there was no phosphorylation, retinoblastoma remained hypophosphorylated, and in hypophosphorylated state, retinoblastoma is active. Active state of retinoblastoma is hypophosphorylated state, and when it was active, it holds EGF transcription factor and cyclin E production is reduced, and there is the arrest of cell cycle. So in this way, there is ceasement, or you can say stopping the cell cycle. So DNA damage activated CDKN1A gene, whose protein product was P21. This P21 inhibited cyclin D and CDK, and when it got inhibited, there was no phosphorylation, and when there was no phosphorylation, retinoblastoma remains hypophosphorylated, and hypophosphorylated state of retinoblastoma is active state, and in its active state, retinoblastoma stops the cell cycle. So in this way, there was a temporary block in cell cycle or quiescence. Now P53 protein upregulates DNA repair mechanisms. Okay, on one way it stopped the cell cycle, on the other way it upregulated DNA repair mechanisms or DNA repair proteins. When DNA repair protein became active, they tried to repair the damage. If damage was small and its repairing was possible, cell will again enter into the cell cycle. However, if the repair was too much, supposedly repair was done, what will happen next? Then P53 protein will upregulate MDM2 protein, and when this protein will be upregulated, what will happen? It will lead to the self-destruction of P53. Okay, so P53 on one side stopped the cell cycle by interacting with retinoblastoma. On the other hand, it upregulated the DNA repair mechanism. If DNA was repaired, then it upregulated MDM2 protein, and this protein led to the destruction of P53, and everything returned to normal and cells again entered into the cell cycle. However, if the damage was beyond repair, what will happen? Cell growth will be permanently arrested. Permanent arrest in cell growth, and this permanent arrest in cell growth is by global changes in the chromosome. Global changes, as you can say, our chromosomes are changed or altered in some way, and CDK inhibitors are activated, and there is permanent stop in cell cycle or senescence. Next is apoptosis. If damage is too much and the cell is not suitable to allow the cell to live, then it activates pro-apoptotic genes, which include BAX and PUMA, and these pro-apoptotic genes lead to the apoptosis of the cell. So it is the normal functioning of TP53 gene or tumor suppressor gene. However, if its function is mutated, normally it is not allowing the cell with damaged DNA to progress and grow and divide. However, if it is damaged in one way or other, what will happen? There will be no arrest to cell cycle, there will be no DNA repair, and cell will continue to grow. And when cell with mutated DNA will continue to grow, what will it lead? It will lead to the production of tumor cells and carcinogenesis. Okay, So it is highly necessary to guard the genome of the cell. However, if it is not present, genome can be damaged and there will be no repairing and no rest in cell cycle, and it will lead to the production of tumors. So one terminology we need to know here is Li-Fraumeni syndrome. What is it? There is also two alleles of the TP53 chromosome, and for carcinogenesis, both alleles should be absent, and which is also not shown to hit hypothesis. However, in Li-Fraumeni syndrome, it is a familial condition in which one gene is mutated genetically, and in such it is called Li-Fraumeni syndrome. In such case, only one mutation or mutation in other allele is required to lead to carcinogenesis, and such person are predisposed to a variety of carcinomas, and they develop cancer at an early stage, and so on. They can lead to different kind of cancer, including breast carcinoma, soft tissue sarcoma, and so on. And oncogenic viruses, for example, human papilloma virus and hepatitis B virus, they can target TP53 and lead to its inactivation, can lead to carcinogenesis. Now we view the diagram of TP53 from book also. This is the diagram of TP53. You can say this is a normal cell, and there it is stress stimuli in the form of DNA damage or hypoxia. What happened? P53 got accumulated and it bound to DNA, and it led to transcription of multiple genes. And what happened? On one side, it induced P21 product of CDK gene or CDK, and this is the protein product of CDK and 1A protein and 1A gene. So it's a product. What it did, it led to the arrest of cell cycle at G1S phase by interacting with retinoblastoma. And on the other side, GADD45 gene got activated and DNA repair mechanism got activated, and there was a repairing in the cell cycle. And if cell got repaired, they became normal cell and enter into the cell cycle again. However, if damage was beyond the repair, they enter into permanent growth arrest, which is senescence. And if there's too much damage and it is not suitable to let the cell live, then Bax gene or apoptotic gene got activated, and it led to the apoptosis or death of the cell. However, if there is mutation in the P53 gene, then DNA damage will not be sensed, and there will be no repair response or senescence or apoptosis. And what it will do, it will lead to the mutant cell, which will continue to grow, and it will lead to the malignant tumor. In this video, we are going to discuss the third hallmark of the carcinogenesis, which is altered cellular metabolism. In addition to other characteristics, cancer cells also show a variable or changed way of their cellular metabolism. What they do, even if there is abundant supply of oxygen, they still move towards the aerobic glycolysis, or they rely upon the glycolysis for their metabolic demands. We know that glycolysis cells rely on glycolysis when there is not sufficient oxygen present. When there is deficiency of oxygen, then they rely on glycolysis or fermentation. However, the cancer cell, in the presence of abundant of oxygen, still rely on glycolysis, and this phenomenon is termed as Warburg effect, or it is also known as aerobic glycolysis, because it is happening in the presence of oxygen. So in the cancer cell, the Krebs cycles and the you can say oxidative phosphorylation is negligible, or you can say at a very low amount. The principal metabolism going on in them is glycolysis, and this glycolysis is monitored usually by using fluorodeoxyglucose, which is a labeled glucose molecule, and it is monitored by positron emission tomography scan. And most of the cancer cells show this scan positive. It means that they show increased glucose uptake. So cancer cells usually have an increased demand of glucose and increased glucose uptake and increased fermentation or glycolysis of the glucose, and they convert glucose to lactate and so on. However, they don't shunt the glucose to the Krebs cycle much. And this is also this Warburg effect is not limited just to cancer cell, but it also happens in the rapidly dividing cells of the body, for example embryonic tissues, as well as the lymphocyte during the active infection. So why it happens? Glycolysis only yields 2 ATP. However, in case of Krebs cycle and oxidative phosphorylation, 36 ATPs are formed. However, when cells want a deficit of the ATPs and choose to be a pathway in which the production of ATP is very low, it is because the rapidly dividing cell, including tumors, including embryonic tissue, including lymphocyte, they also require the metabolites to synthesize their own products. For example, they need metabolites to synthesize lipids, they need metabolites to synthesize proteins, as well as DNA, as well as RNA. So there are metabolic needs they don't require much of the ATP when they will not be having these metabolites. So they don't use all of the glucose for the synthesis of ATP. Instead, they divert this synthesis of ATP towards these metabolites so that they can grow and they can divide and produce more and more cells. Okay, so this is the reason why they don't shunt their all of the glucose to the mitochondria and for Krebs cycle. However, some shunting occurs, and that is in such a way that it only yields about 4 ATPs, and the products, metabolic products from the Krebs cycle are also used to synthesize their metabolites. For example, they use acetyl-CoA from the mitochondria in the synthesis of lipids. So in cancer cells and in rapidly dividing cells, the glucose is oxidized to the pyruvate and in the glycolytic pathway to yield 2 ATP, as well as multiple you can say metabolites which are used to synthesize their own chemicals which are necessary for their division. And there is also a very small amount of shunting to the Krebs cycle and mitochondria, which yields about 4 ATP, and the some products the metabolites from the Krebs cycle are also used to synthesize these metabolic products for the division of the cells. So this is phenomenon is known as Warburg effect. So and then in normal cell, for example, in tumor, so in normal cell, for example, in embryonic cell and in lymphocytes, this process of Warburg effect is regulated. Okay, cells rely on aerobic glycolysis only at the time of need. When need is over, this process shut down. However, in tumor cells, there is no proper regulation, and this Warburg effect continues. Usually, tumor suppressor genes oppose the Warburg effect. However, we know that in cancer cell, tumor suppressor genes are mutated. So when there is a mutation, there will be no opposition to Warburg effect, and tumor cells continuously rely on this pathway and continue to divide. Moreover, there is how this pathway basically works. The receptor cells, which are the growth receptors, we know that in the cell membrane there are growth receptors which lead to the downward signaling. These receptor, when a growth factor binds here on a, supposedly this is cell membrane here and this is a receptor here, and when a growth factor binds here, in addition to leading to downward signaling towards the nucleus, this receptor also upregulates the intake of glucose into the cell. It upregulates glucose intake as well as it upregulates the glycolytic enzymes. Okay, so these receptors basically play a role in Warburg effect. When growth factor continuously stimulate in the receptor, or there is some mutation due to which receptors are continuously being stimulated, they lead to the increased uptake of glucose as well as upregulation of glycolytic enzyme, and they also inhibit the last pathway of the glycolytic pathway, which leads to the phosphoryl pyruvate conversion to the pyruvate. However, the other major factors also play a role in this pathway. Moreover, we previously discussed that RAS mutation or AS mutation is also involved in carcinogenesis, and this RAS mutation is also involved in the Warburg effect. How it plays a role in Warburg effect? It also leads to the upregulation of the glucose intake, as well as it leads to the shunting of this shunting, in which acetyl-CoA and metabolic intermediate of the mitochondria shunted to the synthesis of lipids. So this RAS mutation is also leading to the Warburg effect. Moreover, there is MYC, which was our last product in the previous lecture. We studied that it also promotes growth, and it also leads to the upregulation of glucose and upregulation of the glycolytic enzyme and shunting of the mitochondrial intermediates to the synthesis of cellular metabolites. So RAS mutation receptors, RAS mutation as well as MYC, all this promote to the upregulation of glycolysis and shunting of the metabolic intermediate to the synthesis of lipids, proteins, and cellular components. So they contribute to the Warburg effect. And tumor suppressor gene basically oppose this Warburg effect, and the defects in tumor suppressor gene, including NF1, which was involved in neurofibromatosis, and PTEN, which was involved in certain leukemias, and TP53, which was involved in multiple kind of carcinoma. These tumor suppressor gene oppose this Warburg effect, a continuous Warburg effect in the cell. However, when they are mutated in particular carcinoma, Warburg effect occurs continuously. So in this way, they basically attain their metabolites by diverging the glucose or by preventing the glucose entry into the oxidative phosphorylation, and they continue their needs by promoting glycolytic pathway. Next, altered metabolism is the autophagy. Autophagy is a basically process in which cell eats itself or self-eating. When the cell is nutrient deficient, it begins to eat its own organelles, and it fuses. For example, this was a cell here, and here is nucleus, and here is lysozyme, and Here are its other organelles, and when there is deficient, this lysozyme comes and fuses with them and begin to eat and generate energy, which is used for this cell survival. However, the tumor cell also show an altered response to the autophagy. They can survive even bare energy demands. For example, if they are deficient in nutrients, still cancer cell can survive, and this survival is also due to alteration in their genetic setup. And depending upon signaling, autophagy can be a friend or foe of the tumor. For example, if a tumor is not receiving sufficient nutrition, and it is not even consulting to the process of autophagy, it continues to grow at its normal rate, what will happen? It will become nutrient deficient and will die upon. So, however, some tumor cells respond to the autophagy and they become dormant in this way. And when they become dormant by adopting the autophagy, what happens? They don't respond to the chemotherapeutic drugs. It is because chemotherapeutic drugs basically target the rapidly dividing cells, and when a tumor cell becomes adopts autophagy and becomes dormant, they don't divide rapidly. As a result, chemotherapeutic drugs don't target them, and it leads to the therapeutic failures. Okay, so depending upon the signaling pathway and depending upon kind of mutation, autophagy can be a friend or foe of the tumor. Moreover, the cancer cell also show a special kind of metabolism, you can say oncometabolism, which can lead to the production of oncometabolites. One principal oncometabolite we will discuss here is the 2-hydroxyglutarate. 2-hydroxyglutarate. There is an enzyme called isocitrate dehydrogenase (IDH), which is involved in Krebs cycle, and it converts basically isocitrate to alpha ketoglutarate. So this is the enzyme which is involved in normal Krebs cycle, converting isocitrate to alpha ketoglutarate. However, in cancer cells or in cells which are going to be neoplastic, there is some mutation in isocitrate dehydrogenase enzyme, and when it gets mutated, then mutated isocitrate dehydrogenase enzyme, what it does, it converts alpha ketoglutarate to 2-hydroxyglutarate. Okay, so mutated isocitrate dehydrogenase convert alpha ketoglutarate to 2-hydroxyglutarate, and this 2-hydroxyglutarate inhibits enzyme of TET family, and principal enzyme inhibited is TE2 enzyme. You need not to go into the details of much details of these enzymes. You should remember that this TET2 enzyme is basically involved in the regulation of methylation. It regulates the methylation of the DNA. However, when it is inhibited by 2-hydroxyglutarate, there is abnormal methylation of the DNA, and this abnormal methylation of DNA is not a change in the DNA sequence. Instead, it is a inherited change in DNA without changing the DNA sequence, and this change is basically a epigenetic mutation. So what is happening here? Isocitrate dehydrogenase got mutated. It converted alpha ketoglutarate to 2-hydroxyglutarate, which inhibited TET2 enzyme. As a result, there was abnormal methylation of DNA, and this abnormal methylation of DNA is an epigenetic change, and it can alter the expression of multiple genes. Gene expression is altered, and as a result, gene expression is altered. And as a result of this change, there is neoplastic transformation. So this entire process is called oncometabolism. This process is called oncometabolism. And this particular metabolite which was generated here was called oncometabolite. So in this way, the cancer cells alter their cellular metabolism, and this altered cellular metabolism can help them to survive. However, the altered metabolism can also lead to a neoplastic transformation by inducing the epigenetic mutation, we studied here in the oncometabolism. Thank you. In this video, we are going to discuss another hallmark of the cancer, which is evasion of the cell death. We know that when the DNA of a cell is damaged, or when there is a accumulation of the mutation inside the cell, what happens? Cell is subjected to the apoptosis or the programmed cell death. For example, this was a cell here, and it was nucleus and it got mutated, and there is stress, and it will lead to the programmed cell death or apoptosis of the cell. However, in cancer cells, there is restriction to apoptosis, and cancer cells don't die despite of having too much mutations. So Why it happens? Cancer cells, basically we know that cancer cells are facing a lot of stress, internal stress, which is in the form of mutation, as well as when cancer cells grow, their demand for the blood supply increases. However, the blood supply is not too much to finish their or to sustain their needs, so they are also having the reduced blood supply. Okay, reduced blood supply, as well as they are also suffering from hypoxia. And moreover, when chemotherapy started, these drugs also induce stress to the cell, and it can lead to their death by apoptosis. Okay, so chemotherapeutic drugs, so these are different factors which lead to the stressed internal environment of the cell, and it can lead to their apoptosis. And apoptosis in cancer cell mostly occurs by mitochondrial or intrinsic pathway. So this is the principal pathway which is involved in this entire scenario, by which they can die, and by which they try to evade, by modifying which they try to evade the apoptosis. Other pathway of the cell death is extrinsic pathway, which was a fast pathway. We previously had studied fast. There is fast ligand which bind to fast receptor and lead to the cellular death. However, we are not concerned with that pathway. We will be dealing with intrinsic pathway. So what happens in intrinsic pathway? Basically, we should know some protein factors before we dive into the details of this pathway. There is a protein family which is BCL2 protein family, and this BCL2 protein family has multiple proteins. Some of them are pro-apoptotic and promote apoptosis, and some are anti-apoptotic. Pro-apoptotic members are the proteins which lead to apoptosis, include BAK-BAC and BAX-BAX. These two proteins are pro-apoptotic proteins, and anti-apoptotic proteins include BCL2, BCL-XL, and MCL1. These are anti-apoptotic proteins. And another set of proteins is BH3 only proteins. This is the name, BH3 only proteins, which are basically sensors, and you can call them sensors of cellular stress, and these include BAD and BAD bad, BID bid, and PUMA puma. So these are basically three sets of proteins which regulate the intrinsic pathway. So when there is a balance in favor of pro-apoptotic members, when they become active, there will be apoptosis. When anti-apoptotic members are active, or the balance is towards anti-apoptotic members, there will be no apoptosis. So what should be the basic purpose of cancer cell here, or basic goal of cancer cell here, to avoid apoptosis? They should basically lead to one way or other. They want to inactivate pro-apoptotic proteins. They want to inactivate pro-apoptotic proteins, and they want to upregulate anti-apoptotic proteins. These BH3 protein class 3, they also inclined to apoptosis. They sense the stress, and they also shift the balance towards pro-apoptotic members. Okay, so they are basically, also you can call them pro-apoptotic. So these proteins are pro-apoptotic and these are anti-apoptotic, and now cancer cell want to upregulate these anti-apoptotic members, and they want to inactivate pro-apoptotic members in order to sustain their survival and avoid apoptosis. So how they can do it? One way is upregulation of these protein or anti-apoptotic protein, and yes, they do upregulation. BCL2 is principally upregulated in many types of cancers, and this BCL2 upregulation prevents them from apoptosis. However, in order to avoid apoptosis, they also inactivate these proteins. And how they do it? We know that there is protein P53, the product of gene TP53, and this protein is basically have a strong linkage with PUMA, PUMA, which favors the apoptosis. So what happens in cancer cells? P53 is mutated. Okay, when there is a mutation in this pathway, when it gets mutated, the function of PUMA is also restricted, and the function of PUMA is restricted. There is not a shift in balance towards pro-apoptosis or apoptosis. Okay, so in this way, by mutation of P53, there is also a balance that is shifted towards anti-apoptosis, and apoptosis does not occur. I hope so I'm not complicating the things. Let me summarize. Cancer cells are prone to death by intrinsic pathway or mitochondrial pathway. This pathway is dependent on BCL2 protein family, and this BCL2 protein family has three subsets. One is three principal subsets which we will discuss. One is pro-apoptotic member, which include BAC and BAX, anti-apoptotic member, which are BCL2, BCL-XL, and MCL1, and a third class of protein which is BH3 only protein, which include BAD, BID, and PUMA. So this third class of protein is also inclined to apoptosis. Okay, so you can call them pro-apoptotic also. So this entire set. This entire set you can call it pro-apoptotic, and this set is anti-apoptotic. So cancer cell want to avoid apoptosis. In order to avoid apoptosis, what do? They upregulate these anti-apoptotic members. For example, BCL2 is upregulated in the follicular lymphoma. In follicular lymphoma, there is translocation 14 to 18, in which BCL2 gene is translocated to immunoglobulin chain, and it's upregulated as a result. There is an anti-apoptotic response, and cell don't die, and there is follicular lymphoma, which we will study in the blood system. So in one way, they are upregulating the anti-apoptotic members. In other side, they want to inactivate them. So how they inactivate them? In cancer, there is also mutation of TP53, and this TP53 mutation leads to the down-regulation of the PUMA. And we know that this PUMA was favoring the apoptosis. When it is down-regulated, there is no favoring of apoptosis, and there is also some degree of down-regulation of their function, and cell attain the mutations and don't die. Under normal condition, cell die after accumulating some mutation. However, when there is down-regulation of PUMA, cell sustain survival even after accumulating the mutation, which would normally lead to the cellular death. So in this way, the cancer cell evade the apoptosis. So basically, how apoptosis occurred when there is pro-apoptotic signal, this back and back pathway. What they do, they lead to the pore formation in the mitochondria, and this pore formation lead to the leakage of cytochrome C, and the cytochrome C activate caspases, which lead to the cellular death, which we have studied in the mechanisms of apoptosis. So we will see the diagram here in the book also for our own understanding here. See here what was happening. This cell is stressed by reactive oxygen species, radiation, chemicals, deficiency of growth factor, and so on. So there was a DNA damage, and in DNA damage, when there is DNA damage, P353 response occurred. PUMA was upregulated, and it led to the upregulation of pro-apoptotic member, including BAC and BACs. They induced a hole in mitochondria. Cytochrome C leaked out, and caspase 9 and caspase 3 got activated, and there was apoptosis. However, what cancer cell do? In cancer cell, there is loss of function of P53. It can be either by mutation in P53 or due to overexpression of MDM2. We know that MDM2 holds P53 and prevents its function. So either TP53 is itself mutated, or there is amplification of MDM2. Both these lead to the loss of P53 function. As a result, there is loss of functionality of BACs and there is accumulation of mutation, and there is no apoptosis. Moreover, anti-apoptotic member BCL2, BCLXL, and MCL are also upregulated, and in this way, cell avoids the apoptosis. So it is basically what's going on here. And to summarize it, you can read the summary here, that summary basic understanding, and this summary will be enough for you. Okay, so next we move on. So we know that how we can prevent this from going on and lead to the death of cancer cell. It can be if there is you can say if there is amplification of MDM2, which lead to the loss of function of TP53, you can synthesize drugs which inhibit this MDM2, and when this MDM2 will be inhibited, P53 function will be restored. And moreover, the BH3 proteins, BH3 like proteins can be formulated, which perform in their way, and they also activate the pro-apoptotic members. So in this way, you can target the cancer cell towards apoptosis. However, this is in clinical trials and requires extensive research. Our next topic is next cancer hallmark is limitless replicative potential. We know that in normal cells, supposedly this is a chromosome here, and this chromosome ends, normally chromosome ends have some portion of DNA sequence and proteins which are called telomeres, and these telomeres are basically specific DNA and proteins which are structure which are attached at chromosome ends. And what they do, they basically prevent the DNA repair mechanisms. They prevent DNA repair mechanism of identifying the ends as double strand breaks. Okay, if there are no telomere, DNA repair mechanism become active, and they recognize these ends as double strand breaks, and they can lead to the arrest of cell cycle and senescence. Okay, so what telomeres are doing? They are basically preventing the senescence or the DNA repair response. So what happens when cell continue to divide again and again? This telomere get shortened. Supposedly here was its length this, and in the next division its size will go down. Supposedly In next division, the telomeres have shortened, and in the next division they will shorten more and more, and as a result a stage will come in which telomere length is too much shortened that the cell is not capable of dividing more, and there is loss of cell division. How this loss of cell division is occurring? Because after losing the telomeres, DNA repair mechanism become active, and they recognize these end as DNA double strand breaks. And DNA double strand breaks is basically, you can say, a mutation or fault in DNA that lead to the senescence or arresting of the cellular growth. However, cancer cells require some mechanism by which they can overcome this you can say tragedy of telomere shortening, because it is a tragedy for cancer cell. If their telomeres become short, they would not be able to divide. So what they do to avoid this? Firstly, what happens in cells, there is a, you can say, chromosomal binding pathway becomes active, in which chromosomal ends, you can say this is a chromosome, and this is the other chromosome, and here is telomere, and these telomeres have shortened too much. What happens? Non-homologous chromosome join, and in anaphase these chromosomes moved are attracted towards opposite poles, and there is, you can say, abnormal joining of chromosome, and there is abnormal mitosis which lead to mitotic crisis, and this abnormal mitosis, too much mutation accumulated can ultimately lead to the cell death or massive, you can say, apoptosis. So first there was telomere shortening, and after telomere shortening, if cell tries to divide, or tumor cell tries to divide, there is a mitotic crisis in which non-homologous chromosome join, and they are attracted towards opposite pole, and it lead to massive mutations, and it lead to the massive apoptosis. So what other way they adopt to avoid this? They activate this telomerase enzyme. And when the telomerase enzyme become active, this telomerase enzyme synthesize back these telomeres, and as a result, telomeres length is maintained, and cancer cells don't die off or don't stop their growth. So you can understand it by diagram from the book here. So you can appreciate this is a cell here, and there is an inactive telomere, and when telomerase is not active, cell can maximally live to 50 to 70 division, and after that telomeres are shortened, and when telomeres are shortened, cell is subjected to the senescent state, or you can say it is no longer dividing, and it is sent here by p53 pathway. However, if there is a defect in p53, so what will happen? Non-homologous chromosomal joining pathway will be activated, and what will happen as a result of this? Chromosome will join. You can see this chromosome, these two chromosomes have joined here, and these two have joined here, and these chromosomes are being pulled to opposite side in anaphase, and it lead to the many mutation inside the genetic setup of cell, and this increased mutation can lead to the mitotic catastrophe and can lead to the cell death. However, in order to avoid all this scenario, what cancer cell adopt? They activate the telomerase enzyme. This telomerase enzyme synthesizes back the telomeres, and telomere length is restored, and the cell continue to divide. In this way, cancer cell attain the limitless replicative potential, and they are not subjected to the arresting of the cell cycle. So in this video, we are going to discuss another hallmark of carcinogenesis, which is sustained angiogenesis. So we know that tumor cells are basically an abnormal mass of cells which continue to grow, and for its continuous growth it requires oxygen, it requires nutrients, as well as it needs to remove its waste products. So for all that purpose, it needs continuous blood supply. However, we know that as a size of tumor will continue to increase, when it will be increasing, its demand for oxygen and for nutrients will grow, and it will also need more blood supply to remove its waste products. So tumor growth requires angiogenesis, or formation of new blood vessels which can supply it more and more blood. Okay, so tumor can grow only to 1 to 2 mm in diameter by already present blood supply. After that, it will be needing increase in blood supply. So angiogenesis, or increased blood supply, basically depends upon two kinds of factors. One are pro-angiogenic factors, and other are anti-angiogenic factors. And these the balance between these factors actually determines that new blood vessel will be formed or not. However, the new blood vessels which will be formed are usually dilated, and they have abnormal connections, and they also contribute to the metastasis. So new blood vessels are not only necessary for tumor growth but also contribute to the metastasis. And these new blood vessels are formed under the influence of pro-angiogenic factors, which include insulin growth factors and platelet drive growth factors. And another important enzyme which plays role in the balance between pro-angiogenic and anti-angiogenic factor is protease enzyme. And these factors can be released by tumor itself, or they can be released by strobel cells, or they can be released by the inflammatory cell, which include macrophages and so on. Okay, so principal way by which blood vessels are increased and this balance is shifted from anti-angiogenic factors towards pro-angiogenic factors involves the transcription of vascular endothelial growth factor, which leads to the formation of new blood vessel or angiogenesis. And how this factor is released and its transcription is increased. Basically, hypoxia stabilizes a transcription factor, which is HIF1 alpha factor, and this factor goes to the nucleus and increases the transcription and translation of the VEGF factor, which promotes angiogenesis. Moreover, we know that tumor have the mutation in TP53 gene, and as a result there is down regulation of the P53 protein, and this down regulation P53 basically normally it decreases the level of VEGF factor. However, when P53 is mutated, its levels are down, and when its levels are down, there is alternatively increase in VEGF, which lead to angiogenesis. So TP53 mutation in cancer cell decrease P53 protein, and decrease in P53 protein increases the VEGF factor or vascular endothelial growth factor. Okay. Moreover, P53 also normally encodes an anti-angiogenic factor, which is thrombospondin 1. Okay, so when P53 is mutated, this angiogenic factor is also down regulated. So ultimately, this balance is shifted towards pro-angiogenic factors in cancer cells. Moreover, we know that cancer cells also have a mutation in the RAS pathway, and this mutation in RAS pathway leads to the increased expression of MYC protein, which stimulates the growth, and this MYC amplification also promotes the increased transcription and translation of VEGF, which promotes the angiogenesis. So basically, three principal factors we have discussed here. Hypoxia stabilizes HIF1 factor, which increases the transcription of VEGF. Hypoxia is induced by growing tumor because the blood supply is reduced and the cell don't get sufficient oxygen. And moreover, the P53 mutation is present in cancer cell, and this P53 mutation leads to its down regulation. As a result, VEGF factor is upregulated. Moreover, this P53 also leads to the production of thrombospondin 1, which is an anti-angiogenic factor. When P53 is mutated, this anti-angiogenic factor is also down regulated. Moreover, cancer cell also have RAS mutation, and this RAS mutation leads to the amplification of MYC, and this MYC also increases VEGF transcription and translation. So all these factors contribute collectively toward angiogenesis, and new blood vessels are formed, and these new blood vessels contribute to increased tumor growth, as well as they can can lead to the metastasis. So if in some way this vascular growth is targeted and reduced and angiogenesis inhibited, there is possibility that tumor growth can be restricted. So therapies have been devised. One is bevacizumab, which is a monoclonal antibody. It can block the VEGF and can reduce the angiogenesis. However, the result of anti-angiogenic therapies have not been much successful. There is some way through which tumors escape the therapy targeting the angiogenesis. However, this is the topic of detailed research and demands a thorough research how they escape through these therapies, which lead to the therapeutic failure. So in this video, we are going to discuss another hallmark of carcinogenesis, which is invasion and metastasis. So what happens when tumor grow? They basically invade the surrounding tissues, and as well as they can spread to the distant site, which is the process of metastasis. So what happens in the very first step of the metastasis? What happens? There is loosening of the cellular contacts with each other. We know that cells are joined together by proteins. These are the cells, and these are the connection between cells. These are basically A-cadherin proteins. And these cellular proteins are joined inside on the cytosolic side with the another protein, which is termed as beta-catenin protein, which holds the cytosolic side of this protein. This protein basically holds these normal cells together. However, in cancer cells, what happens? These cellular connections are lost. These cellular connections are lost. When these connections are lost, cell become mobile. they become able to move regardless of their surrounding cells. So what happens after losing these cellular contacts? Cells start invading their surrounding tissues and degrade the extracellular matrix. Supposedly these were the cells here, and what happens, there is extracellular matrix between these cells, and what happens when a cell becomes freely movable, it start dissolving this extracellular matrix. And among the cell there is basement membrane, we know that, which is composed of collagen, fibronectin and other proteins. These cells secrete enzymes which include metalloproteinases and multiple protease, gelatinases and so on. And these enzymes, what they do, they start digesting this basement membrane also. Supposedly these tumor cells arise from epithelium. So these epithelial cells, first they lose their cellular contacts, and then they start invading the basement membrane of epithelium by their enzyme, including metalloproteinases and collagenases and proteases. And these enzymes can be secreted by tumor cell, as well as they can be secreted by extracellular matrix by complex interaction between tumor cell and extracellular matrix proteins. And what happens, in addition, they destroy this basement membrane, they separate to the extracellular matrix and other surrounding tissues, and in this process they can attach to various proteins and cellular markers which are present on the extracellular compartment or other tissues. And what happens in the next phase, supposedly here lies a blood vessel. These tumor cells come here, and this tumor cell start invading the blood vessel wall and enters into the blood vessel, and it can travel in the blood as a sole cell, or it can interact with the platelets and other components in the plasma, and can lead to formation of metastatic embolus, which travels to the distant side, and on distant side it can invade the vessel wall again and can extravasate and can settle at the distant side, which is the homing of the carcinoma. So distant site of metastasis also depend upon certain factors, which is anatomical location of the tumor. It is basically understandable that the tumor will mostly invade and metastasize to its nearby location. However, there is also an important factor, which is vascular drainage. Vascular drainage plays an important role in tumor metastasis. Tumor enters into the blood vessel as well as lymphatic vessels and gets settled in the next other tissues. In case of blood or hematogenous spread, most common site of settlement is the first vascular bed. For example, the tumors rising from GID region settle into the liver because they encountered first capillary bed in the liver, and moreover certain tumors which enter in the vena cava and go to heart, they settle in the lungs because the first capillary bed they encounter is in lungs. So lungs and the liver are the most common site of the secondary mets. Next is also tropism of tumor. It is basically a process in which tumor gets attached to specific antigen or specific proteins or markers expressed in specific tissues. For example, lung carcinoma spreads, lung cancer preferably spreads to the adrenal glands. It shows basically a process of tropism. Adrenal gland have some certain kinds of the you can say proteins or markers which cause this carcinoma to settle into the adrenals. Moreover, in the very same way, prostatic carcinoma prostatic CA spreads to the bones, and this is also due to a process of tropism and so on. So basically, metastasis involves the process of first there is losing of cellular contacts, then it invades the surrounding tissue, its own basement membrane, and degrades the extracellular matrix, and it also gets attached to specific extracellular matrix protein or markers. Then it shows the process of intravasation. Intravasation basically process in which tumor enters into the blood vessel and it travels to distant side. Then shows the process of extravasation in which it moves out of the blood vessel, and then there is homing at the distant side. You can see this at this diagram here, which explains the entire process very well. You can look here. This is the tumor cells, and there's clonal expansion. A specific clone or specific cell grows and divides and produces a metastatic clone or subclone. The subclone, what is it is doing? It invades here basement membrane, it destroys its parent tissue basement membrane, it enters the extracellular space and interacts with other cells and extracellular matrix proteins. Then it comes in the vicinity of blood vessel. It then invades the blood vessel wall, enters into blood, and then it forms a it can travel as a soul cells, or it can form a kind of embolus. Then it moves on here. Then it shows the process of extravasation, and after extravasation, it can form a metastatic tumor deposit at the distant site. So this is the process of basically invasion and metastasis. This motility of the carcinoma is controlled by autocrine, certain autocrine factors, and certain you can say chemokines which are released by both extracellular matrix as well as tumor cells, and form a basically a kind of, you can say, pathway or a chemoattractant pathway which leads to the mobility of the tumor cells. So this was basically an overview. However, the distant site or site of satellite depends upon tropism, depends upon anatomical location, depends upon drainage. However, it is not always true. For example, skeletal muscles and spleen. Skeletal muscles and spleen are rare site of metastasis. It can be due to their unfavorable site for the metastasis because they are rich in capillary beds. However, tumors rarely settle them there because basically carcinogenesis and tumors don't follow usually the rules here. So it is we can predict to some extent that a particle tumor spreads to which side. However, we cannot say with certainty always that at which side it is going to settle. Moreover, there are certain tumors which have more metastatic potential. However, certain tumors don't have metastatic potential. For example, lung, small cell carcinoma of lung always loves to, small cell carcinoma of lung always loves to metastasize. However, the basal cell carcinoma of the skin usually does not show metastasis. However, certain tumors show metastasis at an early stage, certain tumors show it at a very late stage. So it is basically a complex response of the tumor cell to the different factors which are under the research and also require thorough research and investigation to understand this complex process of carcinogenesis. So it was all about today's lecture, and you can use that diagram for your understanding and learning and summary of the topic for your learning. That would be enough. Thank you. In this video, we are going to discuss how cancer cells evade the immune system, which is also a hallmark of carcinogenesis. So tumor cell exhibit different kind of antigens, and these antigens are due to basically certain driver mutation which they have, passenger mutation which they have. These passenger mutation are more common in the cancers which are caused by certain carcinogenic agents, and cancer cell may be due to viral infection, which can be human papilloma virus or Epstein-Barr virus, and this viral infection can also lead to production of certain antigen. Moreover, cancer cell have TP53 mutations, RAS mutations, as well as they have RB mutations. They have certain tumor specific gene mutation. They have oncogenes, and all these kind of mutations, as well as if they are due to viral infection, these all contribute to the development of certain tumor antigens which are present on the cancer cells. And these antigens can be in the form of overexpressed protein, or they can be in the form of mutated proteins, and so on. And usually the antigens are more and more if cancer is caused due to viral infection or if cancer is caused by carcinogenic agents. So due to these tumor antigens, these cancer cells are recognized as foreign cells by human immune system, and immune response occurs against these tumor cells. And this immune response mostly is by cytotoxic T cells response, and sometimes this response may occur against the normal antigen. For example, sometimes this immune response can occur against tyrosinase, which is a normal antigen or normal enzyme. You can say it is present in the melanin producing cells. However, it is not recognized by human normal immune system. However, in certain carcinogenic agents, even this normal antigen is produced in increased amounts, and it can be recognized by human immune system, and the cytotoxic T cell response can occur against this. Moreover, cancer testis antigen is also present in the sperms which don't have MHC1 class protein, and it is not expressed to the immune system. However, in certain cancerous conditions, its expression is increased, and it can be presented to immune system, and immune response can occur against this as well. So in certain conditions, immune response can also occur against normal antigen which may be produced in increased amounts, or the antigen which are not normally you can say recognized by immune system. However, due to their increased production, they can be recognized by immune system, and so on. So how this immune response occurs against the tumor cell? What happens? Tumors are usually hypoxic due to their always increasing demand of the oxygen and nutrients. So some tumor cells die away, and due to death of these tumor cells, there is a release of damage associated molecular patterns, which we know that specific sequences which are present inside the cell, and they when cancer cells die, these molecular patterns are released and they produce damage signals here, and these dead cell particles are engulfed by dendritic cells and antigen presenting cells, which move to the lymph nodes, and in lymph nodes they present the antigen in combination with MHC1 class protein to cytotoxic T cells, and these cytotoxic T cells produce then the cytotoxic T cell response. They amplify and move to the tumor site and lead to the destruction of the tumor. So in order to avoid, moreover, there is also activation of the Th1 subset of cells which produce interferon gamma, and they can lead to the activation of macrophages, and these macrophages can also lead to the destruction of tumors. And in this way, the immune response tries to destroy the tumor cells. So in an immunocompromised person, risk of carcinogenesis increases manifold because immune response is depressed. However, the cancer cell also develop a mechanism to avoid this immune response. What they do for this purpose, they basically lead to the mutation in the B2 microglobulin, and these proteins or microglobulin are essential for the working of the MHC1 class protein. We know that in combination with MHC1, antigens are presented to cytotoxic T cells. However, by inducing mutation in beta 2 microglobulins, there is a decrease in expression of MHC1 class protein, and when there is a decrease in expression of these proteins, immune response is silenced because there will be no antigen presentation. Moreover, what they do, they basically activate immune checkpoints. These immune checkpoints are basically tailored in such a way that they lead to the tolerance or immune tolerance. If immune checkpoint for a particle cell or tissue is activated, that cell is not recognized by immune system and tolerated. So cancer cell activate immune checkpoints in such a way. For example, here is an example. Cancer cell express a protein called PDL1 protein on their surface, and this PDL1 protein, it is recognized by PD1 receptor which is present on the T cells. So supposedly this is a tumor cell against which normally an immune response will occur. However, it has a PDL1 receptor or PDL1 ligand here, and then a T cell, and it has a receptor here. It was destined to destroy this cell. However, when it recognizes this PDL1 receptor protein on the surface of tumor cell, what happens? It becomes silent. It becomes silent and does not respond to this tumor cell. So in this way, PDL1 protein expressed on the tumor cell works in a way of immune checkpoint, and it silences the immune response against the particular tumor cells. Moreover, there are also other protein, for example, CTLA4 receptor, which is expressed on T cells, and it can also lead to the immune tolerance and immune silence. So in this way, on one way, their tumor cell evade the immune system by inducing mutation in MHC1 expression, and on the other side, they activate the immune checkpoints. So certain antibodies are being developed which target these immune checkpoints. For example, if we produce an antibody, supposedly here this was the PDL1 receptor. It was a PDL1 receptor. So if we produce an antibody against this PDL1 receptor which targets this receptor, and if we produce an antibody against this receptor too, then we can avoid this immune tolerance. For example, I can represent here, supposedly this is the tumor cell, and this is the T cell, and here is PDL receptor, and here is PDL1 ligand. Okay, this is PDL1 ligand, and this is PDL receptor. So what happens if we produce an antibody against this? Supposedly we formulated an antibody here which bind here, and we produce an antibody against this too, which came here and bounded this. So in this way, producing antibodies, we prevented PDL1 protein from interacting with PDL1 receptor. So this interaction was avoided by producing antibodies, and in this way there was no tolerance of this cancer, and then T cell will respond to it and will destroy it. However, there are certain side effects to this immune checkpoints blocker. For example, if we are we are avoiding the tolerance of tumor cell, there will be also tolerance of some self tissues will also be lost. Self tissue tolerance will be lost, and there can be autoimmune responses inside the body as well. So immune checkpoint blockage side effect will be most common will be autoimmune responses, which can be managed by anti-inflammatory drugs and so on. Another mechanism to avoid immune tolerance is basically chimeric antigen receptors, and these receptors are being developed on cytotoxic T cells, and they have basically supposedly this is a T cell, and they have an outward directed antibody portion, and inside the cell it activates the cytotoxic T cells, and these are also kind of antibody, you can say chimeric antigen receptors, and they recognize antigen on the tumor cell. For example, this is a tumor cell and here is antigen. They recognize the antigen on tumor cells and activate the cytotoxic T cell response, which lead to the destruction of the T cell. So these specific antibodies directed against tumor gene also being formulated, which are attached to T cell in the form of chimeric antigen receptor, and they also activate the T cell and destroy the tumor cell. However, they also have side effects. For example, they are activating the T cell. So activating, if there is a large activation of T cell, it can also produce its related side effects due to higher production of the you can say chemokine and cytokine inside the body, and inflammatory responses and so on. It was how they were tumor cell were preventing the immune system, and how different therapies are targeting this. Moreover, the tumor cell can also induce the immunosuppression. They can alter the response of the macrophages. They can lead to the fibrosis, and they can activate macrophages in alternate pathway, which lead to the production of immunosuppressive cytokines and so on. Now we can see this from the book as well. Let me show you the diagram here. This was a tumor cell. Tumor cell died out, and dendritic cell picked this antigen, moved to the lymph node, and there they activated the T cell, and T cells divided and produced their copies, which moved to the tumor and destroyed the tumor. So it was a cytotoxic T cell response in response to the dendritic cell. Moreover, you can see here the diagram. This was the tumor. This was the basically a cytotoxic T cell, and this was a dendritic cell which was presenting antigen to it. However, this cytotoxic T cell has a CTLA4 receptor, which we knew that is an immune checkpoint. So it bounded to the B7 antigen on dendritic cell. As a result, there was no co-stimulation, and this T cell was not able to kill the tumor cell and it recognized its antigen. However, we produced an antibody, anti-CTLA4 antibody, which covered up the CTLA4 receptor. Then there was a co-stimulation and T cell became active, and it was able to kill the tumor cells. Now there is another figure here. You can see this is PD1 receptor on the cytotoxic T cell and PD1 ligand on tumor cell. When they are bounded, tumor cell T cell is not able to kill it. However, we produce anti-PD1 ligand antibody and also anti-PD receptor antibody and covered them with antibodies. Then what happened? This T cell was able to kill the tumor and lead to the lysis of the tumor cell. So it was in this video we are going to discuss how genomic instability leads to the carcinogenesis as well as etiology of carcinogenesis. So we know that there is always there are different environmental agents which try to induce DNA damage, and our body has a natural mechanism of correcting this DNA damage, and this mechanism involves different kinds of repair mechanisms. For example, the first one is a mismatch repair mechanism. It is basically supposedly if there is a we know that adenine binds with thymine and guanine binds with cytosine. However, if somehow guanine comes in the place of adenine and guanine binds with thymine and GT bond is formed, it will be recognized as a mismatch, and then mismatch repair mechanism of DNA repair becomes active, and it leads to the correction of this defect. However, if this mismatch repair mechanism is defected, it can lead to the hereditary non-polyposis colorectal carcinoma, which is due to genomic instability caused by mismatch repair mechanism defect. Moreover, microstillate instability can also lead to the this carcinoma or HNPCC. This is basically microstillate are basically DNA sequences which are conserved in the cell divisions. However, if there is a mutation, they are not conserved and they can lead to the development of carcinogenesis. We need not to delve into much details of these topics. We just have an overview of these topics. Moreover, there is axion repair mechanism. What happens in axion repair? If there are two pyrimidines and ultraviolet rays induce a defect and lead to the pyrimidine fusion. For example, thymine binds with thymine and produces thymine dimer, and this thymine dimer is a defect which is it is repaired by axial repair mechanism. What this mechanism do? It excises this dimer and corrects the fault. And this defect in this repair mechanism lead to the xeroderma pigmentosa, in which there is not this defect is not corrected at it due to the carcinogenesis. Moreover, there is also homologous recombination repair mechanism. It is basically an extensive mechanism. We need not to go into the details of this mechanism. It is commonly seen in the Bloom syndrome, which causes different developmental effects, rash and so on, ataxia, telangiectasia, which is characterized by cerebral defect and ataxic changes, and Fanconi anemia, which is also characterized by bone marrow defects and anemia and so on. Homologous recombination repair defect is seen in these three disorders primarily, and it can also lead to the carcinogenesis. So, in normal human cells avoid the carcinogenesis due to DNA repair mechanism. When there is DNA damage, DNA repair mechanism become active and correct the defect. However, if repair mechanism are defected in some way or other, it increases the risk of carcinogenesis. Moreover, homologous recombination repair mechanism defect also arises in BRCA1 and BRCA2 mutations, which can lead to the breast cancer, ovarian cancer, endometrial cancer, and so on. Genomic instability or genomic defects also lead to the lymphoid cancer. For example, RAG1 and RAG2 gene, these are basically involved in the assembly of the immunoglobulins, and also the receptors of leukocytes. However, their defects also lead to the lymphoid carcinomas, and there is also an enzyme which is cytosine activated aminase, and its defect also lead to the development of lymphoid cancers. So just a brief overview is enough for these topics. Next we move towards the etiology of cancer. So genomic instability, however, can also be included in etiology. However, etiology of cancer includes chemical carcinogens, radiation, as well as microbes. So these chemical carcinogens are chemical agents which lead to the mutation and then lead to development of cancer. So you should remember that mutation is basically, you can say, essential condition for development of cancer. So this chemical carcinogen can be direct acting as well as indirect acting. So what are direct acting? Direct acting are basically those which need not to be activated. They need no activation needed to cause cancer. So these include basically alkylating agents, and indirectly acting include polycyclic hydrocarbons, which include benzopyrenes, tobacco, coal, smoked meat, fish, etc. They are found from these sources, benzopyrene basically, and this benzopyrene is activated and converted to epoxide, which bonds with DNA and form covalent adducts, and it will lead to the mutation and lead to the carcinogenesis. Moreover, aromatic amines, including azodyes, the example of these aromatic amines is beta-naphthylamine, which is found in basically aniline dye as well as rubber industry. It can lead to the bladder carcinoma. So indirectly acting need activation. For example, benzopyrene is activated to epoxide, which bind with DNA and form a duct and lead to the carcinogenesis. They are found in tobacco, coals, and smoked fish meat, etc. Smoked meat and smoked fish. Moreover, aromatic amines which include azodyes, for example, naphthylamine is found in aniline dye and rubber industry. Aromatic amines include naphthylamine and which include aniline dye, rubber industry. They can also lead to the bladder carcinoma. So next is aflatoxin, basically aflatoxin, which include aflatoxin B1 toxin, which is linked to the hepatocellular carcinoma, and moreover nitrosamine, which are used in foods, can also lead to the carcinogenesis. So in this here we have discussed chemical carcinogen which include direct and indirect. Direct does not need any activation, indirect need activation. Direct acting include alkylating agent, for example, these are anti-cancer drugs, which include cyclophosphamide and so on. And indirectly acting include polycyclic aromatic hydrocarbon, for example, benzopyrene, which is found in tobacco, coal, and it is also found in smoked meat and smoked fish. It is activated to epoxide, which bond with DNA and form covalent adducts and lead to the carcinogenesis. Moreover, aromatic amines or azodyes, which include naphthylamine, which is found in aniline dye and rubber industry, it can lead to the bladder carcinoma. So it was about chemical carcinogens. Moreover, chemical carcinogens need a promoter to lead to the carcinogenic changes. Basically, chemical carcinogen itself is mutagenic. It induces mutation. Our promoter is not mutagenic. It is not mutagenic. However, it amplifies the response of carcinogen. For example, a cell came and it is defected by mutagenic agent. So what happens next? Promoter exposure, which include esters, phenols, hormones, and certain drugs. This promoter leads to its increased growth or increased, you can say, division and expansion. And in expanding phase, it accumulates more and more mutation and can lead to the carcinogenesis. Promoter itself is not carcinogen. However, in the presence of mutagenic carcinogen, it converts or amplifies, you can say, the effect of mutagen and leads to the carcinogenesis at an increased rate. Next, we come forward with the second major etiological factor of carcinogenesis, which is radiation carcinogenesis. Radiation, including different kind of rays, for example, X-rays, ultraviolet rays, and so on, they can lead to the mutation in DNA and can lead to the carcinogenesis. These rays can induce double-strand breaks double strand breaks, chromosomal breaks, chromosomal rearrangements, chromosomal translocation, etc. They can induce different kinds of mutation which can all lead to the carcinogenesis. Moreover, we have studied in xeroderma pigmentosa, ultraviolet rays can lead to formation of pyrimidine dimers, and these dimers, if DNA repair mechanisms are defective, as in xeroderma pigmentosa, they can lead to the carcinogenesis. However, if the mutation are too much that they overwhelm the response of DNA repair mechanism, it can also lead to the carcinogenesis. So it is the second factor. Next, we come forward toward microbes, which can lead to the carcinogenesis, and microbes include bacteria as well as DNA viruses as well as RNA viruses. So principal RNA virus which can lead to leukemia or cancer is human T cell leukemia virus, HTL1, human T cell leukemia virus. It is basically an RNA virus, and it has specific gene, TAX gene, which codes TAX protein. And this TAX protein, what does it do? It upregulates the expression of PI3, which we have studied in the last pathway 2. It increases the cellular growth. It increases cellular growth, unchecked or unbalanced, you can say, and DNA repair mechanisms are down-regulated. So what happens? Mutations occur, and it also upregulates cyclin D, which also increases growth, and cyclin D inhibitors are down-regulated, which also increases the growth. So overall effect of the human T cell leukemia virus is it has a protein, TAX protein, which is encoded by TAX gene, and it upregulates cellular growth by hampering these checkpoints on the cellular growth. PI3 is upregulated, DNA repair mechanism down-regulated, cyclin D is upregulated, and cyclin D kinase inhibitor are down-regulated. All these factors contribute to the cellular growth. Next, we move toward the human papillomavirus. It is basically a low risk. It has a low risk and high risk subtypes, and it is basically a DNA virus. It codes two major proteins which can lead to oncogenesis. One is A6 protein and other one is E7 protein. These proteins are basically involved in carcinogenesis and plays principal role here. So what happens? A6 protein basically degrades P53, which is the product of TP53 gene, which is tumor suppressor gene, and it also upregulates telomerase. So when TP53 is degraded, that's what happens. Tumor suppressing effect is lost, and it leads to increased cellular growth and increased mutation and increased tumor production. And increased telomerase expression also gives the immortality or limitless replicative potential to the cell, which is basically a hallmark of cancer. So this limitless replicative potential and degradation of P53 are basically responses of the E6 protein. Moreover, E7 protein, it binds the retinoblastoma, the product of RB gene, and RB gene we know that it holds A2F factors and down-regulates the expression of cyclin. So what happens when it binds the retinoblastoma? It frees A2F and leads its increased transcription, and the cyclin is produced, and G1S step is covered, and increased cellular growth. Cellular growth increases. Moreover, it also down-regulates cyclin D kinase inhibitor, so cellular growth also increases. So overall effect of E6 and E7 is increased cellular growth and accumulation of mutation, which can lead to the carcinogenesis, and this increased cellular growth is unregulated or unchecked cellular growth. So what is the difference between low risk and high risk subtypes? 611 strains are low risk and 1618 are high risk. It is basically high risk strains have higher affinity for P53 and retinoblastoma gene. However, low risk have low affinity. So as they have low affinity, their effect is less in causing carcinogenesis. However, high risk subtype have high affinity for P53 and retinoblastoma, so their effect on causing cancer is high. Next, we move toward Epstein-Barr virus, which is also a DNA virus, and it is involved in Burkitt lymphoma, nasopharyngeal carcinoma, Hodgkin lymphoma, natural killer cell tumors, lymphoma in immunosuppressed individuals, and so on. It can lead to multiple kinds of cancers, neoplasms. How it works? It basically binds to CD21 receptors on B cell, and it's basically how it causes Burkitt lymphoma. And on B cell, it also has specific gene, LMP1 gene, which upregulates the JAK-STAT pathway and NFKB pathways, and these pathways lead to the increased cellular growth and lead to the production of lymphomas. Moreover, it produces a specific kind of interleukin, which is a viral interleukin 10, and this interleukin promotes the tolerance of cell infected with the virus. We know that when a cell is infected with the virus, it can express some antigen, viral antigen on the surface, can lead to the immune response. Positive, this was the cell, it was affected by virus, it showed viral protein on its surface, and it was recognized by T cells, and T cells destroyed, attacked, and destroyed it. However, it produces specific interleukin, which is viral interleukin 10, which leads to the tolerance, and T cell does not kill it, lead to the increased cellular growth. Moreover, its protein AB and A2 protein also lead to the increased oncogenesis. So it was basically how Epstein-Barr causes Burkitt lymphoma. It is binding to CD21 receptor, and its gene LMP1 gene leads to the increased upregulation of JAK-STAT pathway and NF-kB beta pathway, and its interleukin 10 leads to the tolerance of wild infected cell, and its protein AB and A2 protein also upregulates the expression of several oncogenes which lead to the carcinogenesis. Next, we move to another two DNA viruses, which are hepatitis B and hepatitis C virus, which can also lead to the carcinogenesis. They basically induce carcinogenesis by chronic inflammation. They induce chronic inflammation in liver, and when there is chronic inflammation and destruction of hepatocytes, they also try to regenerate. And regeneration and destruction go side by side. Moreover, in this process, reactive oxygen species are also produced, which are also mutagenic. So, chronic inflammation, regeneration, and reactive oxygen species, they can all contribute towards carcinogenesis in chronic hepatitis B and C cases, and it lead to the hepatocellular carcinoma (HCC), which is almost always linked with hepatitis B and C exposure. Moreover, hepatitis B also codes the protein HBX protein, which is basically involved in interfering the P53 response, and P53 is a tumor suppressor gene, product of tumor suppressor gene, and function is lost. It can also increase the risk of development of cancer. Moreover, hepatitis C core protein also lead to the hepatocellular carcinoma by interfering with tumor suppressor genes and oncogenes and so on. Next, only bacteria which is included in carcinogenic bacteria is basically H. pylori. These were previously we have discussed virus, including human T-cell leukemia virus, Epstein-Barr virus, human papilloma virus, and hepatitis B, C virus. Now we move toward bacteria which can cause cancer. Bacteria basically H. pylori is the bacteria which can lead to the carcinogenesis, can lead to the gastric adenocarcinoma, as well as lymphoma, which is called maltoma, gastric lymphoma, the maltoma you can say. So gastric adenocarcinoma is basically involved the same you can say mechanism. There is a chronic it induces gastritis in inflammation of the stomach you can say, and when there is chronic inflammation, regeneration, irritation, and reactive oxygen species can lead to the carcinogenesis, as was in hepatitis B and C. Chronic inflammation, regeneration, and reactive oxygen species also contribute to the carcinogenesis. In case of H. pylori, chronic gastritis, it lead to gastric adenocarcinoma. Moreover, it has specific gene you can say SAG-A, which can also lead to the development of gastric adenocarcinoma. It is this gene is present in the pathogenicity inland, which is a specific region in its genome. Moreover, it can also lead to the maltoma, which is basically lymphoid cell tumor, and it is when cells are infected by H. pylori, there is increased T cell response, and this increased T cell response also lead to the increased B cell activation and proliferation, and this B cell proliferation can lead to the development of maltoma. So it was basically an overview of different carcinogenic agents. This maltoma, H. pylori induced maltoma, is basically initially polyclonal, and when there are more and more mutation, it becomes monoclonal, and it is the type of cancer you can say which responds to the antibiotics. So in this video, we are going to discuss about clinical aspects of neoplasia. So clinical effects of neoplasia depend upon multiple factors. For example, the location of tumor, the size of tumor, whether tumor is functional or non-functional, whether the tumor is ulcerated, whether the tumor has shown metastasis to lymph node or distant site, and so on. So basically, effects of tumor on a host are depending upon its location. For example, a very small tumor of the pituitary gland can destroy the remaining normal tissue of pituitary and can lead to the hypopituitarism. Moreover, you can say leiomyoma of the renal artery can lead to the blockage of renal artery and can lead to the hypoxia of kidneys and can lead to the increased renin production and hypertension and so on. Okay, so moreover, the neoplasm, small neoplasm of the biliary tree can lead to the fatal biliary tract obstruction. However, the tumors of the ovaries you can say can grow to a larger size, as well as the tumor in abdominal cavity can grow to comparatively in larger size, and we will be showing a little effect as compared to tumor at these critical locations. So location of the tumor is very important in determining the effects, clinical effects of the tumor. Moreover, the clinical effects of tumor also depend upon whether it is functional or non-functional. What does it mean? It means that it is producing hormones or it is not producing hormones. For example, a tumor of the beta cells of pancreas can lead to the increased production of insulin or insulinoma, and it can be when insulin production is increased, it can lead to the fatal hypoglycemia and so on. More of the tumor of adrenal medulla can lead to the increased production of catecholamines and can lead to the palpitations, increased heart rate, tachycardia, hypertension, and so on. Moreover, it also depends upon whether tumor has shown skin ulceration, which can lead to the bleeding, infection, or not. And moreover, the tumors can also cause the obstruction of GI tract, which can lead to the multiple GI related problems. So, location of the tumor, functional or non-functional status of tumor, or ulceration status of the tumor, determine the effects of tumor. And moreover, you can add up here the extent of local disease, and metastases are also important to determine the clinical effects of tumor on the host. So one more terminology we will study here is cancer cachexia, which is basically a condition which is shown by cancer or tumors. It is basically loss of body fat, loss of lean body mass, which includes the body proteins and muscles. So it is basically wasting of the body, and there is weakness, there is anorexia, loss of appetite, anemia. All this collectively called cancer cachexia. So loss of body fat, loss of protein, that of muscles, weakness, anorexia, loss of appetite, and anemia. These are collectively called cancer cachexia, and it is basically due to it is not basically due to reduced eating. Instead, a normal person, if a normal person eating is reduced and there is starvation, body's metabolic rate, basal metabolic rate, decreases on. However, in cancer patients, basal metabolic rate is always high, regardless of whether patient is eating much or not. Mostly patients are not eating well. However, still their basal metabolic rate is increased. It is because our cancer cachexia is because of the tumor necrosis factor and other cytokines which are produced by tumor, as well as the inflammatory response to the tumors, and these cytokines and tumor necrosis factor lead to the cancer cachexia. They reduce the appetite, and they inhibit the lipoprotein lipase, which degrade the fats and release free fatty acid, and so on. So cancer cachexia is basically a condition whose there is no treatment except the removal of the tumor, the causative agent, which is the tumor. So when there is tumor or carcinoma, there will be cancer cachexia, and you cannot stop it unless the tumor is removed. Okay, so next we move on toward another terminology which is related to cancer or carcinoma neoplasm, which is paraneoplastic syndrome. So if a tumor is a functional, paraneoplastic syndrome basically is a set of symptoms which cannot be explained by local or distant spread of disease. How it means that the local spread of disease or the distant metastasis of disease does not explain the symptoms associated with a particular neoplasm, and it is mostly due to hormone or hormones related proteins produced by neoplasm. For example, hypercalcemia can be shown by different carcinoma cancers, for example, squamous cell carcinoma of lung or breast carcinoma. And this hypercalcemia is usually because they release parathyroid hormone related protein or TGF alpha, or they can also release the active form of vitamin D. And these proteins, that you can say hormonal factors and vitamin D, can lead to the hypercalcemia. So hypercalcemia is paraneoplastic syndrome, which is not due to direct, local, or distant spread of disease. Instead, it is due to hormones produced by tumors or peptides or proteins produced by tumors, which lead to the hypercalcemia. Moreover, tumor also show Cushing syndrome, and this Cushing syndrome is commonly shown by small cell lung carcinoma, and it is because small cell lung carcinoma produces ACTH or ACTH like substance or proteins, and they lead to the increased production of cortisol and Cushing syndrome. So paraneoplastic syndromes are basically a set of symptoms which cannot be explained by local or distant spread of disease, and they are mostly occurring due to hormones produced by tumors. There are different paraneoplastic syndrome which are written here in the book. You can have an overview here. Important one are Cushing syndrome, shown by mainly small cell carcinoma of lung, other carcinoma showing pancreatic carcinoma, neural tumor, and so on. Hypercalcemia, it is shown by squamous cell carcinoma of lung and breast carcinoma. Polycythemia is important here. It is shown by renal carcinoma, cerebral hemangioma, hepatocellular carcinoma. So you should have acanthosis nigricans is important here. It is basically shown by gastric carcinomas, lung carcinoma. Gastric carcinoma here is important. Moreover, it is also shown in type 2 diabetes. So you should have an overview of different paraneoplastic syndromes from the MCQ's point of view here. Okay, next we move on to the grading and staging of cancer. So cancers are basically grading and staging of cancer is important because it helps us to determine the therapeutic effectiveness and therapies for the cancer. So what does grading mean? Grading basically refers to the the extent of differentiation of tumor, and it means how much a tumor resembles to its you can say parent tissue. For example, if a tumor is arising from pituitary, so grading will show how much the tumor cells resemble with normal pituitary cells. So based upon grading, tumor can be low grade, which will be more differentiated, and high grade, which will be less differentiated. So having low grade means high differentiation, and high grade means low differentiation. So tumor having less differentiation is more aggressive, and tumor having more differentiation is comparatively less aggressive. It is basically an inverse response with differentiation. More differentiation, less grade, and less differentiation, more grade. So next we move on toward staging, and this staging is basically extent of spread of tumor, how much tumor have spread or increase in its own size. So for staging, most commonly TNM staging system is used. T here stands for the size of tumor, and N stands for nodal metastasis, and M stands for distant metastasis by hematogenous spread or lymphatic, mainly hematogenous spread here. So TNM is basically size of tumor. Depending upon the size of tumor, it can be T1 to T4, and T1 to T4 are different for different tumors. T1 to T4 are different for different tumors, and T0 shows in situ lesion. It means that this lesion is limited to the tissue itself. It has not crossed the basement membrane of tissue. However, when it will crossing basement membrane, it will not be in situ lesion, it will be T1, and when it will be increased more, it will be converted into T2, T3, and T4. And this classification T1 to T4 is different for different tumors, which is given in the special pathology or systemic pathology. So depending on size, T can be T1 to T4, and T0 shows in situ lesion which has not crossed the basement membrane. N can be N0, 1, 2, 3, and so on. N0 signifies there is no lymph node involved, or cancer cells have not moved to any lymph node. N1 shows the lymph nodal involvement has occurred to one set of lymph node, and then N2 another set of lymph node, N3, and so on. So N2, 3, 4 shows the extent of nodal spread. And M0 and M1 shows distant metastasis. If there is no distant metastasis, it is M0, and if distant metastasis is present, it is M1. And the tumor showing distant metastasis, the M1 positive tumor, are mostly stage 4 tumors. So grading was according to tumor differentiation, and staging was according to the regional and distant spread of the tumor. Next, we move on toward diagnosis. How tumor can be diagnosed. For diagnosis of tumor, principal techniques used include biopsy. In biopsy, a small tissue sample of the tumor is taken, and it is observed in labs for its histological characteristics, and tumor is diagnosed based on this, and this sample should be representative of tumor. FNA is basically fine needle aspiration, in which through a needle cells of tumor are aspirated and they are observed for their characteristics, and it is also helpful in diagnosis of certain tumors. Next is cytological smear. It is basically cytological smear is basically collection of cancer cells from the fluids. So cancer cells are discohesive, or we know that they don't regulate the recadent protein, due to which they fall in body fluids, and from these body fluids they can be observed in microscope, and it is basically used in the diagnosis of cervical cancer. Next is immunohistochemistry, IHC. We depend upon the tumor markers. We have previously studied some extent in the chapter, and in next systemic pathology there is also given that tumors have certain immunohistomarkers. For example, in Hodgkin lymphoma, CD15 and CD30 are the immunohistological markers, histochemistry markers, and they also help in the diagnosis of tumors. Next, there is flow cytometry, which uses the fluorescence technique in the diagnosis of tumors. So these are the principal method of diagnosis of tumor. Next, diagnosis of tumor can also be done by molecular analysis, which is done by FISH and PCR technique. FISH is fluorescent in situ hybridization, only name is enough, and PCR is polymerase chain reaction. These two technologies are used in the diagnosis of tumors. They basically analyze the genetic abnormalities in the tumor. For example, different kind of translocations or point mutation present in tumors, or genetic disturbances are analyzed in the molecular diagnosis using FISH and PCR technique. They help in diagnosis of tumor. They help in finding of the residual disease after treatment. They help in the finding out the hereditary predisposition to particular tumor, and they also help in therapeutic decision for the treatment of the tumors. So it was all about the clinical aspects of neoplasia. Here are neoplasia chapter ends out. Thank you.